Good morning, everybody.
Good
morning. So let's jump right into it. I will say this, there are a lot of people here on a lot of different bills. My intention is we're not going to exec anything today because we have a huge, long calendar tomorrow. So for anybody that would like us to exec the dental benefit today, and I'm going to recommend that it be ought to pass without an amendment. When we get to executive session, don't wait for us to take action on it today. That being said, there are an awful lot of people signed up to speak on this bill. I'm going to ask everybody except the prime sponsor to limit their testimony to 1 minute. As you know, we except for Jess, he gets 2 minutes. We move Senator Rosenwald's bill. This committee supports the dental benefit. Okay? Go ahead, Representative. I'm running the clock.
Thank you, Mr. Chairman and committee members, for giving me the opportunity to introduce House Bill 103. For the record, I'm Joe Shapiro, Representative Joe Shapiro, representing Cheshire District 16, Keene. As you well know, this bill will establish a dental benefit for all adult Medicaid recipients, providing them with preventive and restorative services with the goal of improving the oral health of New Hampshire's low-income citizens. While HB 692, when signed into law by the governor in 2019, created a dental benefit in theory, House Bill 103 is a roadmap for implementation. Work done by DHHS working group and articulates the scope of services and the model of delivery. It also sets clear guideposts going forward with specific date to put out RFPs for managed care companies, a date to apply for waivers from CMS, and most significantly, a date to actually implement coverage, April 1st, 2023. A work group within Health, Human Services, and Elderly Affairs in the House, along with Representative Edwards from House Finance and staff from DHHS, worked hard this past fall to create a dental benefit that would satisfy those on both sides of the aisle. Compromise led to concessions on both sides. This is where House Bill 103 departs somewhat from the current SB 422. Benefits are pared down and co-payments are added. As currently amended, House Bill 103 will provide diagnostic and preventive services, comprehensive restorative treatment, medically necessary oral surgery, and removable prosthodontics. That's a word I've learned since I've worked on this bill. Removable prosthodontics only for the most vulnerable populations, specifically the developmentally disabled, those with acquired brain disorder, people in the Choices for Independence program, and the nursing home population. There is a yearly cap of $1,500 excluding preventive care. Cost sharing will be implemented to the maximum extent allowable under CMS guidelines for those with family incomes only above 100% of federal poverty level. And I would just say that just as I came in this morning, there were some preliminary conversations with myself and some of the stakeholders and Representative Edwards for a further amendment which would exclude from the cap preventive services. So that's something that I think the Senate should consider acting on, and I'm sure Representative Edwards will take part of his 2 minutes to discuss that further. While a dental benefit will come with a cost.
Well, so much for my plan.
While a dental benefit will come with a cost, you can see from the revised fiscal note that over 70% will be picked up by the federal government. As with the Senate bill, the first 2 or 3 years will be paid for with funds from the Centene settlement. In addition, we expect that a dental benefit will result in significant cost savings. With improved oral health, people will be more likely to gain employment and no longer need Medicaid. Expensive emergency department visits will be reduced. Exacerbation of comorbid conditions such as diabetes and heart disease will be reduced, lessening the need for extensive and expensive medical care down the road. This is not the bill that I originally introduced. I acknowledge that I'm concerned about the compromises we have made. I wonder about those who will now be ineligible for dentures and how it will affect their chances of securing employment. I worry about how cost sharing will affect utilization of the benefit, especially preventive care. Nevertheless, compromise means not getting everything you want. While this is a compromise, I believe the program remains a substantial new benefit for those who will receive it. In addition, the bill calls for annual reporting by DHHS, which will indicate trends related to utilization and efficacy, and potentially lead to future tweaks if necessary in the future. House Bill 103 as currently amended was voted ought to pass by a 237 to 100 majority in the House. It has the support of Democrats and Republicans alike. We are getting very close to making an adult dental benefit a reality that will result in tens of thousands of Granite Staters living with less pain and more dignity. Thank you, and please vote ought to pass as amended, and maybe with a new amendment, and I'm willing to take any questions.
Seeing none, thank you very much, and great work on
Thank you.
this bill. Representative Edwards.
Thank you, Mr. Chair. For the record, I'm Representative Jess Edwards, representing Auburn, Chester, and Sandown. And it's been really great working with Representative Shapiro and the rest of the HHS working group on this. What they were willing to accommodate was the perception, first and foremost, that oral health is good health. If you can take care of your mouth, the rest may follow. And similarly, if you don't take care of your oral health, you can suffer other issues. But the other major accommodation in this was to accept that oral health is first and foremost a personal responsibility. Whereas the bill as introduced had the feeling to me and to many others that it was the state trying to do for people what they may not have been willing to do for themselves. And we wanted to make sure that the idea of fairness to the taxpayer was built into this. The fairness to the taxpayer is really why we implemented a copay, because if you go out onto the commercial market and you pay for your own dental insurance, you're going to end up having to pay some copays. So we didn't want to gold plate a benefit for the Medicaid that is above and beyond what it would be out in the commercial market for the people who are paying the tax bill for this. We had an action, just one little detail that just bugs me about this. We had an actuarial take a look at what the cost savings would be by having good oral health and avoiding emergency room visits. And what we found out in that analysis is it's budget dust. It's 1/3 of the management fee for the entire program. So it's really, the fact that we may be avoiding ER visits is really kind of an inconsequential thing. The other thing we did with this bill was to limit who gets dentures, under the belief that people who are in a position to take care of the teeth and have their own sure need should get help from the state. That's why we went with the developmentally disabled. That's why we went with the elderly and the CFI program and in nursing homes, because they were in a stable position to where they could make benefit of the dentures. Now, that's not to say that the other part of the community doesn't get them, because Emeritus, I always screw up the MCO's name, Emeritus Carnitas, it sounds like something I'm going to have for lunch. But what they have done is they've reinvested their 1.5% margin or profit back into dental care. And with this bill in place, they're going to save a lot of the money they would have spent. So talking to them, they're very much interested in looking at a denture benefit instead of what they've been doing. So they cover 22% of the population. So there isn't, because it's a competitive market, people who need denture work can go choose emeritus coronatus in the future and get the denture program from them. So the other thing you should just know for coordination perspective is the Senate sent us 422. This version, the House version, saves just like $500,000 a year. It's not a lot of money, but I think it's easier to explain to the public what we did and why we did it. SB 422 comes to House Finance next week, and what I'd like to do with that is amend it down to the only thing that's remaining in the Senate bill is the risk corridor. I don't know if you remember, but in your 422, you had something about a risk corridor. You had something like 2.4 million out of the Centene money to cover the risk corridor, and I have no clue what that is. So what I would propose doing is stripping 422 down so that 103 is the legislature's bill, and that, but we keep enough of 422 to take care of the risk corridor and the funding that you earmarked for it. So that's my game plan. If you have a problem with that, please talk to me offline or here. But I can take questions.
So, Representative Edwards, do you have the language that you wanted on the change for 103?
I don't, sir. That was just a sidebar conversation here, and so it hasn't matured beyond just a what would you think about this kind of proposal. And what the proposal was is, since the goal was always to emulate commercial dental care, we've very recently, like in the last few hours, have figured out that on a commercial dental program, they typically don't charge a copay for preventive health, preventive work. And my goal has always been fairness in terms of trying to emulate what the commercial marketplace does. If there were an amendment to make the preventive health exempt from the copay, I'd be okay with that. I don't think I'm going to be drafting that, though.
Okay, so here's what I'm going to ask you, to work with Representative Shapiro.
Yes, sir.
To get us that amendment that you want. And I think I have a suggestion that hopefully you'll like. If the House thinks it's a good idea to have the risk corridors in Senator Rosenwald's bill, we could also put that language into 103, and you in the House could put the language that we agree upon with the risk corridors, with the preventive copay not being in there, in both bills so that they're identical. And then you could pass 422, we'll pass 103, we'll both concur, and they both go to the governor, and we have two bills on the governor's desk. And I think that might appeal to the sponsors of, especially Senator Rosenwald, who I haven't spoken to about this idea. But as I said right at the beginning, I thought we were going to just pass this bill as is. But if there's an amendment, then maybe we can do both bills simultaneously.
Yes, sir. I think that's a fine alternative. I'd be happy to go down that path. I would also point out, though, that this bill would not go into effect until 1 April. So in theory, we could deal with the copay issue on the preventive health in a separate bill next year. But
I don't see any reason not to deal with it now.
Okay.
I think it's better to deal with it.
Yes, sir.
Now.
All right.
So I'm going to rely on Representative Shapiro and you to get back to us with what you want in 422 and the language on the copay and the preventative. And then we probably won't exec this until next week
Yes,
at the
sir.
earliest. and then you can do the same thing to 422.
Yeah,
Does that make sense?
It does. I just would need to put a little disclaimer in there, is that I have no idea what a risk corridor is. I don't know if it's a good policy or
Mr.
not.
Lippman is going to, in his testimony, explain that.
Okay,
So,
all right. Well, thank you.
great, all right. Representative Pearson, do you want Mr. Lippman to go first, or would you like to go now? Okay,
Mr. Chair, may I introduce my guest?
yes, I'm sorry.
No problem. Thank you, Mr. Chair, and I appreciate your patience. I just wanted to introduce my guest today, Lindsay Marquis. She is a Girls Rock the Capital, part of that program. She's a high school student in Nashua, and I just wanted to welcome her to Senate Health and Human Services. Thanks.
For the record, I'm Mark Pearson, Chairman of the House Health, Human Services, and Elderly Affairs Committee, and according to the union leader, a bleeding heart conservative, to which I plead guilty. My desire in chairing my committee is to try to come to consensus whenever possible to do good for people and in a cost-effective way. I think the compassion of this bill or these bills is obvious, but the finances, as I did my research, I discovered that bad dental health often leads to bad person health, and to expend some money up front to fix a small problem often mitigates spending a lot of money down the road to fix what has become a major problem. I was the one that took to the floor to get the Bill 103 through the House. I thought we might win by 10. We won by a lot more, proving there are people who understand you can be cost-effective and compassionate at the same time. So that's just my testimony. As the chairman of the committee, I'm thrilled to see this bill come forward.
And again, congratulations to all the House members who've worked so hard on this bill on a bipartisan basis.
Thank you, sir.
Great. All right. Henry, and then Mark, if you could call Tom Raffio after Henry.
Good morning. For the record, Henry Lippman, Medicaid Director. I'm going to limit my comments to the question at hand. If you have other questions that come up later, I'm going to stay till the end of this part of the hearing. So the Centene settlement came as a result of a financial practice that Centene had that affected the risk corridor that New Hampshire had in place. The risk corridor was put into the managed care contract during the pandemic, early phases in particular, to make sure that there wasn't a windfall profit or unfair loss. And so the value of that transaction was to protect the state. So what ended up happening is, because of a reporting issue, that Centene overstated their cost, which was the basis of the state getting the settlement. The costs, part of the cost that was overstated belongs to the federal government in terms of getting their share of overpayment back, if you will. And so the $2.4 million that was in original 422 is to put the Department of Health and Human Services in the position of, okay, we helped get this settlement, and we should use some of the settlement to pay back the federal government as opposed to having to take it away from another program. And that's all it is. Risk corridors are part of our ongoing contract because there's still a lot of instability with respect to medical utilization. And so it isn't sort of a program that's part of this. It's just a byproduct of how the settlement came about and the fact that we do owe money back to the federal government. And so rather than taking it out of another program, we're saying take it out of the settlement, which I think would have been expected to be the original intention. And obviously, under state law, the legislature has to approve any use of a settlement fund, and that's why it's in the bill.
Questions? So I'd suggest, Representative Edwards, if you have any questions, talk to Mr. Lippman offline.
And I'd like
Great.
to thank both the Senate and the House for really working hard on this important bill.
Good morning. How are you, Tom?
Fantastic. Good morning, Chair Bradley and members of the committee. I'm Tom Raffio, and I heard everything on the laptop out there, so I'm clear and I won't be redundant. I've been CEO of Northeast Delta Dental since 1995, so this is a 27-year effort for me, and most recently, a lot of my colleagues have been participating on the working group, including the actuary that was referenced. I think Representative Shapiro and Edwards have really described what my life is about, which is convincing the world that the mouth is part of the body and that you can't have good overall health without...
Except for politicians, right?
Well, good point. But I've tried to, in my career, I've tried to connect the head to the body, whether it's oral health, mental health. And so this bill is consistent with our mission to improve oral health for everybody. Our new mantra, to keep it really simple, is everybody deserves a healthy smile. Not just those of us that have traditional group dental insurance or individual insurance through the public exchange, but everybody deserves a healthy smile. So, of course, HB 103 does differ from the bill that you all supported, or most of you supported, Senate Bill 422. As you know, 422 does not have the cost sharing that has been referenced a couple times, nor the limitation on dentures. So, of course, I believe that removing those barriers would be great. However, candidly, having been around for over a quarter of a century, we support passage, of either bill. We've got to get the ball past the goal line. So at the end of the day, I think it's more important that Granite Staters have access to dental care, and let's not quibble over the exact plan design. Let's get it in. So in my view, passing HB 103 as is might be the simplest thing to do to get the ball moving forward. And that would actually fulfill my lifelong professional dream of having an adult dental Medicaid benefit. When I moved to New Hampshire in 1995, that was my goal. So either bill is great, but let's get it done, and if that means getting on board with HB 103, let's do it. And of course, all the speakers before me have explained the importance of oral health. And those actuarial studies, that was our actuary, Courtney Morans, and FSA, was part of the working group, and we continue to loan her, to make the case. So, thank you. I hope we can get it done and get moving on it in July of 2023. Thank you, Senator Bradley, and all of you for your leadership. I think the time is now. Thank you.
Okay, thank you. Senator Sherman, question?
You said no. Thank
Yeah,
you.
well,
Real quick question. That actuarial, did they talk at all about, I understand the ER visit issue, but did they look at all about the benefit to somebody in terms of ability to get a job? A lot of the people who are in their young 20s or early 20s, late teens, they have poor dentition through no fault of their own. They never had care as a child. And this bill will not be allowing some of those people to get dentures. Is there a fiscal impact that your actuarial looked at?
So we provided a lot of this to the working group, and there's a famous study called the Wakely study, which basically, demonstrates, some of those points. We all realize, of course, there's a whole self-esteem component of this. You're not going to be able to interview well for a job, but the dollar and cents for cost figures are more related to the reduction in the emergency room and the connections with other medical conditions, and less sort of the mental health related to not having good teeth to be able to interview. But of course, I would love if there was no limitation on the dentures, but I think we've got to get it going. Thank
Great.
you, Senator
Thank you,
Bradley, and
Tom.
all of you.
you're welcome. Carla Smith, New Hampshire Nurse Association, good morning.
Good morning. My name is Carla Smith. I'm a registered nurse, and I'm here today to represent the New Hampshire Nurses Association. To keep it brief, I'll just focus on these two paragraphs here. The need for Medicaid recipients to have access to dental care continues to be critical. Oral health is critical to one's overall health and well-being. Poor oral health increases the risk for diabetes, cardiovascular disease, premature birth, low birth weight, decreases employability, increases ED use, and overall healthcare spending. New Hampshire residents with lower incomes have decreased access or availability to dental care and are more likely to have adverse oral health and chronic illness outcomes. Access to oral health increases the ability for Granite Staters to obtain and maintain employment, learn and study, and achieve and maintain sobriety. Currently, New Hampshire relies on a Medicaid emergency dental response only, which only perpetuates ongoing problems and pain until it reaches expensive and necessary treatment. Early oral health detection and prevention is better for everyone's health and is more fiscally responsible as well. The members of the New Hampshire Nurses Association ask you to support the passage of this important bill. On a quick side note, as a registered nurse, I have worked for 10 years previously at Portsmouth Regional Hospital in the emergency room. I can't tell you, almost every single shift I worked in that length of 10 years, we had multiple patients come in with complaints of dental pain. This is a reality. I think it's more than just costs. I think it's also the time and the strain on our resources. Our EDs are overfilled with patients with chronic disease, acute injuries, mental health crisis, and just by eliminating that portion of patients who are seeking care in the ER, regardless of the costs, I think is a huge benefit. Thank you very much.
Great. Seeing no questions, thank you very much. Ms. Rosenberg, how are you this morning?
I'm doing well. How about you?
Good.
Thank you. For the record, I'm Karen Rosenberg. I'm the Policy Director at the Disability Rights Center, and it's great to be here to testify in support of HB 1513. Wrong bill. Oh my God, HB 103, and hopefully see an adult benefit come into reality in the state. I do hope that an amendment will be brought to address the cost sharing, especially with regard to preventive services, because when you look at what a family of four would bring in terms of their income, if they were earning minimum wage, they'd be above federal poverty, would be $30,000 a year or so. And when you look at the fair market rents in cities like, this is from the New Hampshire Housing Finance Authority's latest report, Nashua, $1,628 a month fair market rent for a 2-bedroom apartment. And if you're bringing home, but I guess the $30,000 would actually be before taxes. So you're looking at over half of your income for rent, and what is that going to leave for food and your other expenses? So I'm hoping that there will be an amendment to at least take out preventive services from the cost share so that people can get that access and find out whether they need the treatment. But in either event, this is a really great day for New Hampshire, so thank you so much.
Great. Thank you. I'm not sure I'm going to pronounce this right, but Ms. Lydia Yen? Good morning. How are you?
Good morning. I'm good. Can you hear me with the mask on? Okay. So I'm here to testify in support of HB 103 and also to testify on behalf of Lisa Bodwin, the Executive Director of ABLE New Hampshire. She wrote her testimony, but I'll try to keep it short since there's a 1-minute limit. Dear Chairman Bradley and members of the Senate Health and Human Services Committee, my name is Lisa Bodwin. I am the Executive Director of ABLE New Hampshire. On behalf of our members across the state, allies, and the Board of Directors, we strongly encourage you to support HB 103 and, more importantly, commit to passing a benefit program and the funding for an adult dental Medicaid benefit across the policy finish line. It is imperative that the New Hampshire Senate and New Hampshire House work together to prevent pursuit of perfection from achieving the good. First, I'd like to thank you for your resounding support of SB 422. Able New Hampshire and its constituents are so encouraged to know that for a second year in a row, the New Hampshire Senate remains in unanimous support of an adult dental Medicaid program and its funding. As you know, Able New Hampshire and the disability community have been advocating for this policy improvement for several years. HB 103 and SB 422 represent the combined efforts of many experts, elected officials, managed care organizations, public and private providers of oral health care, and most importantly, consumers who have all once again come together to build a feasible framework for taking New Hampshire's most important positive step forward in healthcare policy. People with disabilities experience the poorest health outcomes of any identified population in America. As you have previously heard from Able New Hampshire, the data is clear that people with poor health struggle to secure employment among the many consequences of poor health. People with disabilities already face discrimination in our society from potential employers who believe the myth that people with disabilities are not quite worthwhile employees. As a population, people with disabilities experience the highest rates of poverty of any identified group, in part due to these types of myths. So to close, if New Hampshire is interested in raising rates of employment as well as improving health outcomes for people with disabilities, we must finally make providing fiscally sound and comprehensive oral health the law in New Hampshire. I have handouts from Able New Hampshire and also like 4 or 5 more testimonies from members of Able New Hampshire.
Great.
Thank you.
Thank you very much, ma'am. I would now recognize David Donahue. While we're finding him, Mr. Corvo, for about 10 seconds.
It's just enough time to get my name in the record. Thank you, Mr. Chairman. Garth Corvo, for the record, Garth Corvo. I'm an attorney with the Bianca Professional Association representing the New Hampshire Dental Society, composed of 1,100 of New Hampshire's dentists and dental professionals. I'm submitting written testimony. Just to summarize it, New Hampshire's dentists have been working on this issue with all of you, particularly Senator Bradley, for several years, including the HB4 working group, and have been instrumental in designing this benefit. We're very comfortable with it and support it. We support House Bill 103. We are aware there are some relatively minor policy differences between Senate Bill 422 and House Bill 103. Like Tom Raffio stated, we support both bills. We think it's time to get one to the governor's desk and enact it into law. And if you have any questions, happy to.
Seeing no questions.
Yeah, I
Thank
thought
you.
so.
All
Thank
right.
you, Mr.
Now
Chairman.
we'll get to the last speaker, Mr. Donahue. Good morning, sir.
Thank you, Chairman Bradley, honorable members of the committee. My name is David Donahue. I'm the Executive Director of WellSense Health Plan. We are one of the 3 Medicaid managed care organizations in the state. By membership, we are the largest Medicaid managed care organization in the state, and we're the state's only not-for-profit health plan. I'm here to speak in support of HB 103. Not to be repetitive, but as a number of the other folks have stated, we believe that oral health care is health care, and this bill would increase our ability to collaborate and work with the existing dental providers in the state to provide better overall health care for our members.
Great. Thank you very much. Okay, I don't think we have anyone else who's signed up to speak. Go ahead, quickly.
So I just had a quick addendum of something I meant to mention relative to dentures. And that is, out of this concept of fairness, I just want you to understand where the part of the denture carve-out came from. When we have National Guard and reservists who deploy into the sandbox for 6 months to a year, they're not entitled to any dental insurance, but when they're deployable and they have orders, the government pays for a full dental check, and if they have tooth decay and rot, what the military will do is they'll remove all of the bad teeth, but they will not do any removable prosthodontics. And so even though they're going to the sandbox to fight for us and then they come back, they do not have a removable prosthodontics benefit. And so that was another guardrail that we used as we were trying to make sure we were fair.
Okay, great. Thank you very much, Representative. Okay, seeing no one else who wishes to speak on 103, we'll close the hearing and we'll open the hearing on House Bill 583 and recognize the sponsor, Representative Cambrell. Morning. How are you?
Good morning, Mr. Chairman. Thank you so much for taking the time to listen to. I'm going to keep this very simple. House Bill 583 does one very simple thing. It allows New Hampshire residents that have decided to donate their organs via the DMV database just to extend their rights a little bit further by allowing them to designate that their organs be considered for New Hampshire citizens first. Okay, there's a reason why we're doing this. UNOS, who is the United Network for Organ Services, changed a ruling last year of their policy that has devastated the New Hampshire people that are on the organ waiting list. The system used to be probably the most fair system that I've ever encountered. I myself am a kidney transplant recipient. I had a life-saving transplant 2 years ago. The system before March 15th of last year was probably the best federal agency administered service that I've ever encountered because it was very fair and equitable. We used to be part of a region in New Hampshire was part of 6 states, Maine, Massachusetts, New Hampshire, Connecticut, Rhode Island, and half of Vermont. And we as a region took care of ourselves. We are, the states are all donor states, which means that relative to the population, we have a lot more people sign up to be donors relative to the population. So we always had a very good, a good amount of people signed up to be donors. And the typical waiting list time was 3 to 5 years, which is reasonable. As of March 15th of last year, UNOS changed the policy to a 250-mile nautical radius. The effect of this, as you can imagine, we're New England, we're small states. 250-mile radius now includes big cities like New York City, Newark, New Jersey. And the effect of this has been because those big cities have huge populations and they have long waiting lists with long wait times, the effect has been that all of our deceased donor organs are now being funneled down to those states, and our New Hampshire citizens are not being considered. That is the reason why we're presenting this bill. As I said, the system that they had before was perfect. It was an incredibly well-run system. They're the ones that changed it. This bill is the only hope now that a New Hampshire resident will have to possibly get a deceased donor organ, because it gives them just a little bit of an edge. So let me just say, I wanted to sum it up very quickly, what this bill does and what it does not do. Okay. What it does is it simply allows, when somebody signs up at the Registry of Motor Vehicles, today they have 2 choices. Do not sign to be a donor organ, or organ donor, or sign to be an organ donor. We will add an additional line that would say, if my organs are to be used, we would like New Hampshire citizens to be considered first. Now, having said that, That does not change whatsoever the current allocation system, okay? All it does is that all other things being equal, then the New Hampshire person would be considered first. So if you have a person that's been on the wait list for 8 years, their current criteria, it doesn't change anything. It just says if you have a tie, the New Hampshire person would get consideration because it was an organ donor after all. So I wanted to keep it concise because I know you have, you're going to hear a lot of opposition today from a lot of lobbyists. As I said, I would be the first person to say that they do an incredible job. They had a perfect system. They changed it. The change is discriminatory and punishing to small states because, again, as you can imagine, even though it's a national policy that they've set in place, if you're in Texas, 250-mile radius, you're still in the same county. You're in New England, 250-mile radius, you just usurped all of New England. So I'll close with that and just say that you may hear from the lobbyists today, you're going to hear threats. They're going to try to intimidate you with falsehoods. They're going to say that there's a law that we will be in conflict with. There is no law. There is no federal law. This is just a federal policy. And I would ask that you question them on some of the things that they're going to say to intimidate. The only law that would be a true law would be this one if we pass it. And again, it's just meant to level the playing field just a slight bit because of the discriminatory policy that they've put in place that adversely affects the small states here in New England. I thank you for your time.
So, one question, Senator Avard.
Thank you,
Yes.
Mr. Chair. Just real quickly, if other states do this, will this, the same method, won't this hurt New Hampshire citizens as well?
Thank you for the question. No, it will not, because first of all, the only other states that would likely to do this would be Massachusetts, Vermont, because they're also being usurped. They used to be part of our family. They're also now under the same circumstance that we are. They're within that 250 nautical miles. It would not hurt New Hampshire because people that live in New Hampshire can be registered, and they are registered in other states to have transplants done, Maine, Massachusetts. And again, all this bill would simply do would be if an organ becomes available and there's a tie due to the current allocation system, they would get consideration first. But this does not affect New Hampshire whatsoever because you can be listed in other states. People are listed in other states to get, for example, we don't do heart and lungs here. You would do that probably in Massachusetts. Again, no, to answer your question, that's one of the things you will hear. It will not hurt the people of New Hampshire. What has hurt the people of New Hampshire is this policy that they've put in place, which has now usurped the organs. I have one set of data that I can give you. Dartmouth, Hitchcock, for example, kidney transplants. We have 1 year of data now because this was enacted last year in March. They've lost 66% of their deceased donor organs that they should have had, given the average statistics. So,
Thank you. Senator Whitley, one question.
Thank you, Mr. Chair, and thank you for taking my question. So that's the data issue is what I was interested in. So besides the data that you mentioned from Dartmouth, I mean, it's only been a year, so do we have actual numbers for, showing that New Hampshire residents are waiting longer or, having other consequences? Do we have that data available?
I can tell you, because I was a patient just up to 2 years ago, that the overnight from when they introduced the new policy, the doctors up here were telling people that you're no longer 3 to 5 years, you're now 8 to 10 years, and you're likely, probably, in many cases, never going to see a transplant because a lot of people die while they're waiting. But it absolutely did affect the wait times here already.
Seeing no further questions, up, Senator Gray.
Did I hear you correct? You said nautical mile and not regular mile?
Thank you, Senator. Yes, that is nautical miles. So that, again, that would encompass a lot of the big cities that are out of state.
Thank you very much, Representative.
Thank you, Senator.
I would now recognize Representative Pearson.
Thank you, Mr. Chairman, members of the committee. Once again, for the record, this is Mark Pearson. I chair the House Health, Human Services, and Elderly Affairs Committee, and I am not a lobbyist. For the record, I am an organ donor, and my driver's license so indicates. I wish to speak against House Bill 583. I was originally a sponsor as the initial concept was outlined, but since giving my initial approval, my knowledge of the subject has increased considerably. The Speaker of the House asked me to do as much research for him as I could, and I did quite a bit. Though sincerely offered, what is being advocated in House Bill 583 is, in my opinion, wrong for 3 reasons. Number one, it goes against federal law, whether literally or the spirit of that law. While a person may donate an organ to a specifically named friend or family member waitlisted for that organ, one cannot specify organs go to a member of a narrow group, such as people of one's particular race or religion or income level. Secondly, the protocol in place is to provide the organ to the person most in need of it, who is the best match in terms of blood or tissue type, and is close enough that the organ taken from the donor will not go bad before it's transplanted into the intended recipient. These protocols are wise and fair. Third, if we restrict New Hampshire organs to New Hampshire residents, or at least by the implication that they should be somehow given greater consideration, again, who's to say that Massachusetts won't do the same? We have but one organ transplant center in our state. It's way up at Dartmouth-Hitchcock, and it only does kidney and pancreas transplants. For people in southeastern New Hampshire and all of New Hampshire, for every other kind of organ, people have to go out of state, and that's often Boston. But wait, your loved one is in Boston awaiting a transplant, and an organ now becomes available. But it's from a Massachusetts donor, and now they have a law similar to ours. And so your loved one now does not get that, even though your loved one is on the top of the previous protocol list. Why would Massachusetts do that? Perhaps reciprocity or retaliation. So for these reasons, although one understands the thoughts behind the original bill, my research led me to deep dive, to see what's going on, to see what the professional organizations have as their database, and so now I must urge an expedient to legislate. Thank you, Mr. Chairman and members of the committee.
Questions of Representative Pearson? Seeing none.
Oh, just one.
Oh, sorry.
Thank you. Thank you, Mr. Chair. So I just, my understanding in the committee, the vote was unanimous in support, and so is this new information that you learned since then?
This bill went to transportation, not to me,
Got it.
because somebody saw the word driver's license. And I begged to get more work. And we, and I will not define who we is here, decided sometimes one house saves the other one, and we're looking forward to that here. We are.
Thank you.
Thank you very much, Representative. All right, I have several other representatives signed up, although they haven't indicated they wish to speak, but I see Representative Kirk. Oh, you're here on embalming. Good. Okay, we'll go right from the top. I'm going to ask for 1-minute testimony from folks at this point. Kelly George. Good morning, ma'am. Try to do the best you can. I'll be flexible. I even allowed a question from Senator Sherman.
That was Senator Whitley, although we are like brother and sister.
Good morning. Thank you for the opportunity to speak with you this morning. This year I celebrate my 13th anniversary of my heart transplant. Saved my life. On December 3rd, 2009, I received the gift of continued life from an anonymous donor. Prior to my transplant, I struggled each day with end-stage heart failure. The fluid in my lungs made it difficult to do everyday activities. Once listed, each day brought anxiety and worry, wondering if that call would come that would say a heart was ready to save my life. Because New Hampshire's only transplant center, Dartmouth-Hitchcock Medical Center, does not perform heart transplants, I was referred to Tufts Medical Center in Boston. Together, the two centers cared for me until that long-awaited call came. On December 2nd, 2009, I made my way to Massachusetts, received my transplant, and have enjoyed a full life since. Hearing the words, "You have 2 years, maybe less to live before you need a transplant," was devastating. If the state of Massachusetts were to adopt a bill such as HB 583, it would be just as devastating to hear, "I'm sorry, this heart is only for a Massachusetts resident." I would not have lived this past 12 years with my husband and my family, and I definitely would not be sitting here with you today. I urge you to honor the ethical and responsible policy of sickest first, which has been demonstrated to save more lives, including my own, and soundly reject the alternatives that needlessly put transplant patients at risk. Thank you.
Are there questions of Ms. George? Seeing none. Thank you very much.
Thank you.
I think Teresa Grinnell. Okay, while we're waiting for Ms. Grinnell, Rusan Chester. No, Kirk, I asked him.
Therese Gradell, Loudon, New Hampshire, hospice nurse. I understand I only have a minute to speak. I just want to say that in my experience as a hospice nurse, I have seen a dramatic increase of people who have been waiting for a transplant for a kidney and were not able to obtain one. Understanding Jose and his intent in this legislation, I'm absolutely appalled that we don't give an option for New Hampshire constituents to get the care that they need. To hear that there's a 66% increase in those waiting here in New Hampshire for a kidney at Dartmouth-Hitchcock is just tragic. And I would beg you guys to consider making that additional box. There's a lot of people out there, I don't know if you have any idea how many people are out there, but there's a lot of people that are going to remove their option to donate their organs in fear that they're going to New York and God knows where they end up at that point, and that our own here in New Hampshire are being bypassed and waiting 5 to 10 years versus 3 to 5. You cannot wait that long when your kidney is failing. Please, I support this, and I ask that you do the same.
Thank you very much. Alexandria Glazier. Good morning, ma'am.
Good morning. I'm Alex Glazier. I'm not a lobbyist. I'm the president and CEO of New England Donor Services. We're the charitable nonprofit that operates the federally designated organ procurement organization that's responsible for coordinating organ donation and transplant in all 6 of the New England states, of course, including New Hampshire. For the committee's general understanding, federal regulations require all hospitals to refer deaths to the OPO, that's the Organ Procurement Organization, my organization, so that medical suitability for organ donation can be assessed at that time, authorization for the donation secured, and then the organs that are donated be removed and allocated. So it is our organization that is responsible for allocating organs in accordance with federal policy. So let me just start by saying New England Donor Services opposes this bill. It's not a simple bill. This is not about just a checkbox at the DMV. This would, in fact, completely change the way organs are allocated, and it would be detrimental to the patients who are waiting. I did submit very detailed written testimony. I certainly will not go through that right now. I want to just say that there are 3 primary reasons that we oppose this bill. It is clearly preempted by federal law. That's not just policy, but it's statute and regulation. And that law establishes a national system of organ transplantation that's necessary to maximize the number of lives saved throughout the entire country. Also, this bill directly conflicts with state law, New Hampshire state law, which does not permit donations to be made to categories or groups of people. And that is really important because it's been recognized through the Uniform Anatomical Gift Act that individuals should only be able to donate to another specified individual, like a parent or sibling, if in fact there's a medical match at the time that the individual dies and the donation is made. Otherwise, we're opening it up into categories of individuals, gender, race, maybe social affiliation, politics, et cetera, which has been largely found to be unethical in the allocation of organs. And this brings me to my last third point and reason for why we oppose this bill, which is it is contrary to the ethical principles of organ allocation. Organ allocation needs to be based on medical factors and criteria. Urgency, how critical is the patient waiting, and how long have they been waiting? The new policy that you've heard about, let me just briefly touch on that. There's a new policy that went into effect last year. And so what that did was standardize the geographic units, because in the past, the unit of allocation, you heard about the region here, varied very widely throughout the US. And so now it's used a standardized geographic unit of 250 nautical miles. You're correct about that. And so what that does is make sure that there's a consistent distribution of organs for the sickest patients first within a geographic area that makes sure the organ remains viable. It's also important to note that this policy is transitory. It's continuing to be improved. And the expectation is that the initial impact, which might have increased time waiting in some places, will equilibrate so that the time waiting is the same everywhere. The point is that a patient's place of residence should not be determinative of how long they wait. Last thing I'm going to do is just give you a little bit of data. You already heard Dartmouth-Hitchcock is the only transplant center here. They're kidney-only transplantation. Patients from New Hampshire who need kidney transplant overwhelmingly go out of state. 2 times the number of kidney transplant patients are transplanted outside of New Hampshire than inside New Hampshire. And of course, as you already heard, hearts, lungs, livers, New Hampshire residents must go out of state for those transplants. So the bottom line here is that we're very concerned that this would upend a carefully calibrated system of organ allocation. It would conflict with federal and state law, and it would really be to the detriment of patients everywhere, particularly in New Hampshire. This should be rejected, and frankly, organs are allocated to patients, not to places. I'm happy to take any questions about the system.
Just a quick question.
Quick questions?
Thank you, Mr. Chair. So we heard some testimony about, how in 1 year this has changed wait times, but I heard something that you said about perhaps because it's only been 1 year, wait times might be longer, but they're going to reach equilibrium. Do you have a sense about how long it will take the system to reach that equilibrium?
Yes, great question. The reports from the federal agency and the data is public anticipate that this would be less than 2 years. Also, as I mentioned, the policy is in process of being further reformed so that it's patient-specific rather than 250 nautical miles. It would look at the acuity, how sick a potential candidate is, and how far they are from where the organ becomes available, and make that calculation. So there would be no hard boundaries at all. There's nothing about this current policy that discriminates against anyone in the country. In fact, quite the opposite. What it does is make sure that patients everywhere have equal access to organs.
Senator Gray?
I'm interested in how these circles are divided and whether, being in the part of the country we are, we may be just in one circle, but a community like New York City may be in 2 or 3 or 4 circles, which might give, someone an advantage, if they have. So if you could provide that to me offline,
I'd be happy to. Keep in mind, the circle is drawn around where the organ becomes available. So for example, if the organ became available in Maine, it is not going to reach to New York. If it became available in Connecticut, it would reach to New York. And also keep in mind that New York organs then are available in our region as well. Many, many more donors in New York than in New Hampshire.
Senator Sherman.
Does the geographical, thank you for taking my question, does the geographical, this change, does it take into account population, or would that change the, you partially answered that in the last answer, but does population figure into how you look at these circles?
That's a great question. Population as an independent factor does not, but keep in mind that the number of candidates waiting for transplant is somewhat of a proxy for population. And so, for example, there are far fewer patients waiting for transplant at Dartmouth than in Massachusetts or in New York. And there are also many more donors in Massachusetts and New York. I can say that throughout our region, the rate of donation is excellent. You already heard that. And it's comparable between our states. So this is not pulling organs from one place that has a higher rate than others. What this is really designed to do is make sure that the wait times are roughly equivalent for patients who are similarly sick throughout the country. There is, by the way, no ability to break a tie with a residency. You have to prioritize one patient over another. It is simply not, I think, feasible to say that all things being equal, they're never equal.
Okay, thank you very much.
Thank you.
So Representative Weiler contacted me yesterday, has an unavoidable conflict, and he is the prime sponsor of House Bill 1131, so I'm going to recess temporarily the hearing on House Bill 583 so that Representative Weiler can testify. I'm going to open the hearing on House Bill 1131. As soon as Representative Weiler has testified, we'll go back to the other hearing. Representative Weiler, good morning. So recess and open.
Thank you for the accommodation, Mr. Chairman, members of the committee. Representative Ken Weiler, Rockingham 13, introducing House Bill 1131, dealing with face masks for children. Forcing our students to wear face masks interferes with their learning and breathing. This age group has the lowest experience with serious COVID infections, and data show little difference between groups forced to wear masks and those not wearing them. So I have the name of the person that I'm going to ask to you call on first after me when you get to that, and it's Stephen Petty. It's in number 5 there, and I'm happy to answer any questions, but most of those will be left for others, and I appreciate the accommodation. Thank you, Senator.
Any quick questions of Representative Weiler? Seeing none.
Thank you very much.
Okay, we are going to recess the opened hearing on House Bill 1131, and we will resume the hearing on House Bill 583, and I will go back to recognizing Mr. Chester.
A public hearing, and it should be available and open to the public. It is not. I've watched this now since before COVID. It was a problem. Now, this is a huge issue. The fact that this is a public hearing and it's not public is not okay. Regardless, I'll take that elsewhere. What I will say with regards to the organ donor bill is that
I have been instrumental for years, I have been an organ donor. And I have been instrumental in getting other peoples to donate organs. And I can promise you, if this bill does not, if it is allowed, if our organs here in New Hampshire are allowed to go anywhere within this radius, right now, before this policy change, we had a 3 to 5 year wait. Now we're looking at an 8 to 10 year wait. Why? Because it's not fair that New Jersey or New York doesn't have as many donors. Not our problem. This is New Hampshire. We had an agreement with a number of states surrounding us that would allow for people to get organs donated. I had a 24-year-old mom of 4 that died last year. Her heart now beats in a man in Upper New Hampshire. What I will tell you is you will see a huge decrease in the organ donation if this is allowed to, if this policy stays in place. I will do what I need to do because I promised people that the organs that they donated, if they became a organ donator, that it would go to our people, the people surrounding our area. And that's part of the reason why the organ donation is so huge in New Hampshire, because we do care about our community. We care about our state. We care about the people of our state. The people out there is proof of that. That's all I have to say, but I really seriously think you folks need to consider the choice that they said, oh, well, it's just going to be 8 to 10 for everyone and we won't discriminate. We have done huge amounts of activism in this state to have the number of organ donors available that we have.
Thank you, Ms.
Don't take that away.
Thank you.
Thank you.
Is there questions from committee members? Seeing none, thank you very much. The next one on the list is Aaron, I'm going to say Contino. After Aaron is John Marasco. Are you Aaron?
I am.
Okay.
I'm Erin Contino, New Hampshire resident. When I was 6 months old, I had a virus attack my heart, which caused me to go into heart failure. For a year of my life, I went through medical trials, but eventually my heart was functioning at 1% and I was placed on a wait list for a heart transplant. I had a mere 24 hours to get my heart, or else I would have died. And I was fortunate enough to have my heart transplant. My case was a unique situation where I was so sick, they were able to go outside of the normal range and match me with a heart from Missouri. As it stands today, organs are given to the sickest eligible person, and in November of 1996, that was me. This bill aims to allot organs based on geographic location, and in doing so, it would deprive the neediest person of a life-saving transplant. I feel this bill is short-sighted. Today, we have one transplant center in the state, and it only focuses on 3 organs. This automatically excludes a large population of recipients and those in waiting. As a small state with already limited medical resources, this will only drive people to receive care elsewhere. I count my blessings this limitation did not exist in 1996, or else I wouldn't be here today. I wouldn't have gotten married. I wouldn't have welcomed my 7 nieces and nephews. I wouldn't have graduated from college, attended my prom, and much more. Overall, the concept of organ hoarding undermines the primary premises of organ donation, which is altruism as a final act of a person's life. Thank you for your consideration.
All right, thank you. Questions from committee members?
Just real quick, Mr. Chair, when people are here to testify, can I also know, are you in favor or against?
Against.
Thank you.
Thank you. Next on the list, John Marasco. And T.J. Leiden is the next one. After John is T.J. Leiden. Yep.
Good morning, everybody. Morning. My name is John Marasco. I'm the Director of the Division of Motor Vehicles, and I know that you have a lot of people that want to testify, so I'll be very brief. We oppose the bill. The reason that we oppose the bill is based on a lot of what Representative Pearson has already presented. I did have a conference call last week with Alex Glazier from New England Donor Services, and she highlighted many of the problematic areas associated with the bill. So the legislators have recognized the importance of organ donation in New Hampshire. Many recipients are very thankful for those opportunities, and we wouldn't want anything that would potentially derail the program here in the state of New Hampshire. So for legalities that could potentially be involved, other states that could follow suit with a bill such as this, and how that could adversely affect New Hampshire citizens going out of state for a transplant, and on a smaller scale, the cost of the DMV, which would be about $64,000 to change up the icons that would go on licenses and update our system, which produces those. We would oppose the bill at this time. I'll take any questions.
Other questions? Seeing none. Thank you very much.
Thank you, sir.
What did I do with my?
Leiden is the next.
Good morning, Senators. I'm Thomas Leiden. I'm an ER doctor in Dover, New Hampshire. I'm here today for the Medical Society, and we oppose this bill. It may seem strange for an ER doctor to come and speak on this, but anytime someone dies in the hospital, and they often die in the emergency room, we are obligated by law to call the organ bank. So I work closely with Alex. I've spoken to her previously, and we deal with the organ people all the time, unfortunately. We have done a donation at my small hospital. It was a tremendously helpful procedure for the family and for the people who receive the organs. I have come to trust these people without hesitation. And I will note that during the last 2 years, during the horrible COVID crisis, it was only the enormous cooperation which we physicians had in the state with doctors in Maine, in Massachusetts. I sent a child recently to Connecticut because we didn't have any beds in New Hampshire, and I've sent patients to New York, and they were more than happy to take our patients. So this level of cooperation that we benefit from in emergency medicine doesn't really respect state borders, and I think it works tremendously well. So we oppose this bill. Thank you.
Thank you very much. Seeing no further questions, I don't believe there's anyone else signed up to speak on 583. So we will close the hearing on 583, and we'll open the hearing on the next bill, 1018, and I believe Representative Goley is in the hall. Yeah, you should see the room out there. Yes. So, no questions. I've limited testimony on everything. I'm limiting your questions and yours.
I have no questions. I know.
Thank you, Representative Goley. We will open the hearing on House Bill 1018.
Thank you, Senator Bradley. And for the record, Representative Jeff Goley, representing Hillsborough District 8, Manchester's Ward 1, and here today to introduce House Bill 1018, which was a request of the OPLC, moving the Board of Medical Imaging and Radiation Therapy into an advisory board over in OPLC. And in doing so, when the language was brought forward, from the director. The eDNA committee made some changes to the original bill, making sure that if you look at of the amended version, some of the things we put in were on page 3, line 28. Most of the stuff that is done by the executive director shall be done in consultation with the board, so that the board still maintains the autonomy of helping make decisions when the director goes to make changes in rules or anything that may go forward in what is given directive to the OPLC director, so that we want to make sure that the board is consulted with in making those changes, that the executive director isn't just making those changes on their own. It is in consultation. So those were the main changes in the amended version of the House, and I'm not sure if the director is here or not. She was in the hallway earlier.
She has signed up to speak. So seeing no questions of Representative Goley, we thank
And
you
I will
very
be
much.
brief. Thank you.
And if we could try to find Ms. Courtney. She is the only other person that signed up to speak on House Bill 1018.
Lindsay Courtney.
I have no idea. Good morning. How are you?
Good morning, Mr. Chair, members of the committee. I apologize. I was at EDNA, so I ran over here. I'm trying to monitor a couple of different things. Well, I appreciate the time and opportunity to appear before you in support of the bill, which would effectively convert the Board of Medical Imaging and Radiation Technologists to an advisory board. Just give me one moment. I'll pull out my written testimony that I have for you all. So essentially, what we experienced during the COVID-19 state of emergency was that a number of our healthcare boards were experiencing quorum issues. And unfortunately, in the state of New Hampshire, when a licensing board that has independent regulatory authority experiences a quorum issue, there can be no effective regulation. There's no ability to issue licenses. There's no ability to promulgate rules regarding licensure and disciplinary action, and there's no ability to take disciplinary action. So essentially, there's no alternative plan for that part of government, and government essentially breaks down. So we observed that during the pandemic, in particular with some of our healthcare boards, and I think part of that was driven by the fact that they were actively working in the healthcare fields and needed on the front lines and not necessarily in board meetings. And there were several concerns that we had, obviously, with this process, which was we were issuing licenses automatically by operation of law after 60 days, as we are required to do under RSA 541-29A, without regard to whether or not the individual is actually qualified. And as you may appreciate, given that we have healthcare workforce shortage, 60 days is an awfully long time for somebody to wait to be licensed. At the same time, if the person does not meet the qualifications, that's an extreme risk to public safety. So that was one issue that we observed due to lack of quorum. The other issue is that, of course, we have been receiving complaints. If the boards are not meeting, we are not effectively able to do anything with regards to those complaints. And essentially, what is the purpose of licensing the profession if we can't appropriately respond to complaints of misconduct? So with respect to this particular board, at the time we were considering which boards to potentially move to an advisory model, which, by the way, it already exists in New Hampshire. We have 4 boards that are advisory boards. Vermont employs this model for a lot of the smaller boards, which I would consider this to be a small board. We thought that MIRT would make more sense because at the time they had not convened a quorum on a consistent basis. I will say that they have been meeting more regularly, so I want to be completely transparent with the committee. We do still have concerns regarding the consistency of meetings and therefore believe that given the small size of this profession, the fact that the composition is particularly difficult to find people to serve, that it's more appropriately an advisory board that would allow the state to continue to regulate and protect the public. Some of the concerns that you may hear regarding just moving to advisory boards in general is that how can one person effectively regulate 54 different professions? I've heard that on numerous occasions. And I think that's really based on a misunderstanding of administrative law in general. If you look at the statutory structure of all state agencies, let's take HHS for example, it requires the commissioner to perform all sorts of duties that she does not personally perform. And so really what we need to do is marry both the people who have expertise in their professions with the people who have expertise in administrative law. And that, and we ensure that actions are carried out in accordance with appropriate statutory and regulatory framework through internal controls. So I do not think that the executive director needs to be a medical imaging radiation technologist. I think we just need to have sufficient statutory and regulatory framework to ensure that we are appropriately communicating with individuals with that expertise. And again, I'm sorry, I'm out of breath with that. I need to work out more. And with that, I'm happy to answer any questions.
Thank you very much.
Thank you very
Back
much.
to ED&A.
Thank you.
I've heard it's crowded over there too. Oh, one question, Senator Sherman.
Really quickly, are you comfortable with the changes the House made?
Yes, the changes the House made were to confirm and to assure that we were consulting the boards with the who have the professional expertise, and I think that's entirely appropriate.
Great. Thank you very much. I don't have anybody else signed up to speak on House Bill 1018. So we'll open the hearing on House Bill 1044. And good luck. Yeah. Recognize the prime sponsor, Representative McLean.
Who said crossover was tomorrow?
I saw that.
Morning, Mr. Chair. For the record, my name is Representative Mark McLean, representing Manchester in the town of Litchfield, and I'm here today as the prime sponsor for HB 1044 and to speak in support of the bill. Simply put, HB 1044 allows healthcare facilities that utilize a membership-based or a direct pay method to be exempt from the provisions of RSA 151:2-F, which requires that you take on all forms of payment. And so, simply put, the real driver behind me wanting to bring in this bill is to try to bring some increased level of transparency into the healthcare marketplace, which is something that's been important to me for quite some time. Just as an illustrative example, this is, I bring this example up just because it's very simple. In 2018, I was in a very minor car accident, no major damage being done, and so fine. But my wife wanted me to go to get checked out just because, is there something, maybe have whiplash or something like that. But I hadn't really filed a claim with my insurance company because it was very minor damage. I went down to the urgent care and I said, look, I just want to have a going over, but because I haven't filed a claim with my insurance company, I'm just going to pay cash. So if you could just give me a feel for how much that's going to cost. If it's $100, I'll get it done. If it's $1,000, obviously I want to mollify my wife, but not to the extent of $1,000. And they said, unfortunately, we have no means of being able to provide that to you. The bill will come, and you'll kind of figure out what you're responsible for at that time. But we can't even tell you if it's $100 or $1,000. And the reason that I chose that example is, first of all, because it happened to me, but also because it's a case of very simple exchange. There's no anesthesia, there's no surgery, nothing like that. And I was paying cash, so the third party is completely removed. And even in that simple case, they were not able to provide any level of transparency. And I could imagine for more complex things, it would be even more difficult for folks. And I was thinking, as I was preparing for this testimony, back to the 2012 debate between then Congressman Charlie Bass and Annie Custer. And the Affordable Care Act had just come in at that time. And so a lot of the discussion went around where had the Affordable Care Act succeeded and where had it failed. And there was general agreement between the two candidates that, yes, indeed, it has expanded access in certain areas, but where the Affordable Care Act had really fallen down was on its promise to start to bring costs down. And it really hadn't delivered on some of the transparency that it had promised. That was, I think, one of the main goals that President Obama, when he brought forth the ACA, it wasn't just access, it was to bring in the transparency, bring down the cost. And I think it's something that both Republicans and Democrats can agree on, that we'd like to have more transparency, because we've all been in the place where we get the bill from the hospital and we open it up and we have no idea what's inside. So I've submitted legislation in the past to try to provide upfront pricing. And, I got a lot of feedback from people I respect saying, listen, you really can't do this. There are complexities here that you don't understand. You're really trying to kind of hammer in on the issue, and it's just not going to work. So HB 1044 kind of gets around that complexity issue and coming in with the legislative hammer, because what it does is it builds on the direct primary care payment model that we brought forth a couple years ago. And what it does is it expands it to healthcare facilities so that if they operate on the subscription or the direct pay model, then they're freed up of the complexities of the private insurance, Medicaid models. And what that will do is that will, I think, allow facilities which adopt that model to be completely transparent in their pricing. I mean, if you're going to go to that, and you're going outside of your insurance, what is the carrot? The carrot really is the fact that the pricing is transparent. So if you look at the handout, why I think that's important is I just gave you a little supplemental handout from our New Hampshire Insurance Department. And you can see, if you look at page 3 and 4, if you look at where we are with respect to the healthcare deductibles, New Hampshire, we have a very high enrollment and high deductible plans, and our deductibles go well above the national average, and I don't know if I made it all the way around, but our deductibles are amongst the highest in the region and definitely above the national average. And if you look at the last page of the supplemental handout I handed out, you can see year over year over year, the enrollment rate in the high deductible plans keeps going up. So it's not going down. The amount that are going into these plans are more and more and more. And yet, if you look at studies to see how many people, because of the fact now they're being enrolled in high deductible plans, you would think that would incentivize folks to be going out and kind of comparing costs. And what various studies have found, including the Journal of American Medicine, the Journal of the American Medical Association study, which I kind of cite there, is that really, even when folks have high deductible plans, they're not doing a lot of shopping around. And I think the reason for that is that it's just very, very difficult to get at the transparency side of things. So if new facilities came to New Hampshire and took advantage of the payment models that HB 1044 allows, then pricing transparency for the patients that use those facilities, it's going to become crystal clear. You're going to know the pricing up front. So for the uninsured, for the self-insured, and for those with high deductible plans, I think that would be very, very attractive. I don't think that you would see a huge shift. There's not a lot of this in the country at this point, but if you look at the direct primary care model, we're not seeing the amount of enrollment in direct primary care exceeding 5% at this point. Everything is relatively new. But I don't think that you would see with healthcare facilities, if I adopt that model, that you would have an uptake rate that would just kind of take through the roof. And also, there are no existing facilities that do this at this point. They're not in existence anyway. This basically just creates a starting point for them to be able to go forward and take advantage of that model. So one of the things that I heard from a lot of the folks that I really respect, and this was brought up as well on the floor of the House, is that there are concerns that maybe HB 1044 is going to go after the state's critical access hospitals and maybe steal away some of the premium patients. But it is important to know that the other protections that we have in the law, with the exclusion zones and other protections, those are all preserved by HB 1044. The only provision that is changed within those protections is the payment model itself. And I know that under federal law, critical access hospitals do receive favorable reimbursement from Medicaid as well. So I think we're not going to see a massive impact against the critical access hospitals, but I think the benefit is the real way that critical access hospitals and all hospitals indeed, I think, can deal with any threat that might come about is just to move towards more transparency themselves. One of the reasons I think that I failed in the past and even the Affordable Care Act didn't succeed is because it came down kind of with the legislative hammer. The subject experts with respect to moving towards transparency really exist within the system. It exists within the hospitals. It exists within the insurance companies. That is where the subject expertise lies. And that, I think, is where ultimately the solutions on transparency are going to come from. So rather than come down with a hammer, I just think that HB 1044 will bring the opportunity for a little bit of competition to maybe incentivize them to take advantage of that expertise and move us towards a place of more transparency. And that's my testimony. And if you have any questions, I'll be happy to do the best I can.
Seeing none. Thank you very much.
Thank you, Mr. Chair.
So next speaker will be Representative Knirk, and then followed up by Representative Leon, who's probably in the hall.
Yeah, there we are. Okay, well, thank you very much. For the record, my name is Representative Jerry Knirk. I'm also a retired spine surgeon, so I have a little experience in the healthcare type of issues as well. And again, as you all know, and the sponsor has spoken about it, that currently licensed healthcare facilities are required to provide services to all persons regardless of the source of payment. And that requirement was added, and it was a good requirement, back in 2016 to ensure access for low-income individuals and those covered by Medicaid, because it doesn't make much sense to have Medicaid if there's no place you can go because nobody will take your insurance. So this bill would exempt from this requirement the healthcare facilities that provide services on either a membership-based model or people who make a direct payment without submitting to insurance. And that's one of the difficult issues. A lot of discussion was just made about high deductible plans. This won't help that because the way that your deductible gets whittled down is you submit the bill to your insurance company. They then credit it. They deny it, but they credit it against your deductible, and that's how you meet your deductible. So if you decide to go in and pay it, you've done nothing to whittle down your deductible. The bottom line, this will allow a small number of for-profit institutions to be able, so for example, institutions might offer urgent care, birthing services, ambulatory surgery, any of those kind of things, to skim off the patients who pay the full cash price. But that'll change the payer mix of the remaining hospitals. And it really will go beyond just the critical access hospitals, but those are probably the ones that will be impacted the most. It's important to realize that our hospitals, particularly the critical access hospitals, run on razor-thin margins. Even when they do get that greater reimbursement that was just mentioned a moment ago, that still barely allows them to be in the black, and they're still often even in the red. They lose money on services, such as having a 24-hour-a-day full-service emergency room, or an obstetrical service, which is often paid for by Medicaid or people with no insurance. As a result, those services, which are really critical to have in the rural areas, they're subsidized by the higher paying procedures, like getting a total knee done or a total hip done, and also the higher paying insurances. So if you skim off those higher paying patients, there'll be a significant negative impact upon the upon the bottom line of the hospital. And it will have a distinct economic effect on those hospitals. And not just the critical access, but I think the other hospital as well. But again, it'll be most difficult for critical access. This will lead to a substantial risk of hospital closure, which we have been seeing around the country, and particularly in rural areas, or the need to drop critical services, such as maternity, which we saw Lakes do not so long ago. Now, this is going to leave us a problem, particularly in rural areas, because there'll be no access for medical care for emergencies or childbirth. The losses for those facilities that do stay open will be shifted to those who have insurance, further increasing the cost shifting and just driving up the cost for everyone else and not really changing the total health care costs. Now, our hospitals recognize the threat to this bill, and they have opposed this bill in its former iterations in the past because they see the need for all the hospitals to share the burden equally. And then RSA 151-4A that does have the licensure near critical access hospitals, which I served with Senator Bradley on the committee to work on that one, sets that 15-mile radius. Well, I live over 15 miles from either Memorial Hospital or Huggins. I have to drive over 15 miles to get service for anything in any facility. So if you stuck a facility of one of these kind of facilities in Tamworth, let's say on Route 16, one of our most heavily traveled areas, it would not be governed by 151-4A. It's outside the 15-mile radius, but it could skim off the high-paying patients from both Huggins and Memorial. So the sponsors present this. It wasn't presented as much here, but it certainly was in our committee, as allowing the free market to function. But it doesn't. This does not support a free market. Giving favored treatment to a certain set of facilities who use one business model at the expense of the others is not a free market move. So don't be baffled by this free market concept. And there's also comments made about transparency. And there's a difficulty with transparency. When you walk in the emergency room, you don't always know. The person at the receptionist can't tell you exactly what the fees are going to be, because we don't say, sorry, your time is up, your money's up, you're out of here, you're not going to get that workup you really deserve. We don't know what the problem is until a person comes in and tells us their history. So in summary, this bill will probably decrease access to health care, it'll put our hospitals at risk, and it will not drive down the overall cost of health care. I really think it should be ITL. I should actually make one other comment. There are some models for these ambulatory surgery centers who say, here's your price for a total knee replacement. Lovely. You go read their fine print, you find out a lot of things that aren't included there, a lot of things that might change. For example, if you have to stay overnight more than one night, and that's not included. So even that is not the transparency we'd like. We also know that our insurance department has done a great job of increasing transparency for certain procedures, which you can find on their website. So that has been addressed, though it is quite difficult. I mean, basically, unless we're going to redo the entire healthcare system, adding this in is not going to make it work. Thank you. I'll take any questions if you have any.
Thank you, Representative
Thank you.
Clerk. Representative Leon? While we're waiting for her, if Ms. Minahan is available. Good morning. How are you, Paula?
Good morning, Mr. Chairman, members of the committee. For the record, Paula Minahan, Senior Vice President, State Government Relations with the New Hampshire Hospital Association, representing all our hospitals in the state. We are opposed to House Bill 1044. The bill exempts facilities operating with membership-based or direct payment business models from certain special licensing provisions. We do have concerns about this bill as it would impede access to services if a healthcare facility is not required to have a charity care policy in place. We have questions about the intent of the legislation, and I apologize. It was hard to hear out in the hall, but I was trying to listen to the testimony of the sponsor, and I did hear some of Representative Knirk's testimony, which I am 100% support and appreciate. This bill would include hospitals and facilities such as ambulatory surgery centers, hospice facilities, urgent care centers, and birthing facilities. In addition, it includes special health care service licenses that are newly licensed under our state licensing statute to include cardiac catheterization, lab services, open heart surgery, and coronary artery bypass graft surgery, and megavoltage radiation. The bill, as we read it, would allow for these types of facilities if they exclusively provide services to persons who have a membership-based arrangement or make direct payments to not accept all patients regardless of their ability to pay and to not have a charity care policy. As Representative Knirk has stated, hospitals and all facilities, it is a requirement currently, and we support that. We do not believe in this two-tier system, which we believe this bill would promote, and we do not believe it's in the best interest of patients seeking care in these facilities to not be assured that the facility maintains a charity care policy. I'm also not aware of any licensed healthcare facility that only accepts payments directly from patients or operates on what's called a membership-based business model. That was a new term to me that I heard, and that was introduced in a separate bill that got kind of, for a number of reasons, that bill was tabled, and that concept of membership-based was added to this bill. It is not really defined, but it is a unique term to me, and I've been around for a little while, and I've never heard of such a model in the health facilities type of environment. That would mean that a facility would not take any form of insurance, even a high deductible plan is insured, you're still insured, so they would not take any form of insurance, including Medicare, Medicaid, or any third-party health insurance. And it is worth noting that the original language was amended in the House to incorporate this language, membership base. That was House Bill 1347. And I do not believe this bill is appropriate, and we ask that you find this bill an expedient to legislate, and I'm happy to answer any questions.
Thank you, Paula.
You're welcome.
We have your written testimony.
Yep.
Great, thank you. Representative Leon.
Thank you very
Good morning.
much.
How are you?
I'm doing well. Thank you. I'm sorry, I was in a different meeting. Thank you so much for having me here. I'm Representative Erica Leon. I represent Derry. I'm Vice Chair of the Health and Human Services Committee in the House. This bill is important because we've seen how much centralization we have of medicine today. Right now, CMS policies are dictating the way that medicine is practiced, not just in any private facility, not just in any healthcare's office, but especially in the hospitals. I know that a lot of important points have already been made, but I'm concerned about the possibility of surgeon brain drain. If we have surgeons who aren't willing to comply with some of the mandates that are coming down from Medicare and Medicaid, they may choose to retire. They may choose to retire early. And surgeons can't operate outside of a hospital. So they may move to other states that are a little more permissive with their allowances for people to have exemptions, or they may simply choose to leave medicine. Having an option for facilities that don't take Medicare and Medicaid would give another option for surgeons who may want to stand up a hospital in order to stay in the profession so that they can keep seeing patients and doing what they've dedicated their entire lives to do. As a medical device analyst on Wall Street, I went to a lot of cardiology conferences, orthopedic conferences, neurology conferences. I saw the first time that people came together for implantable heart valves that went through the blood vessels. It's quite amazing what can happen when people come together. I also know that this may never even come to fruition in New Hampshire if we give them these allowances. There's a lot of forces that come into play. This probably would only happen in the southern part of the state because you'd need to have people who'd be willing to travel, possibly coming up from Massachusetts to see some of our specialists who would be working here. They wouldn't really be impacting our critical access hospitals up north because unless they're operating some sort of resort facility where you come up, you get your leg, and you come stay and enjoy our lakes region, which actually would be a great draw. But unless you have something like that, it's not really going to impact our facilities up north. I see this as an option to allow our surgeons, allow our oncologists, allow other highly trained, highly specialized medical professionals to have a chance to operate outside of the CMS-controlled paradigm. Because these last 2 years, if they've shown us anything, they show that Washington controls a lot more than we realize. And having a small escape valve here in New Hampshire, I think would be good for our doctors and for our citizens.
Very good. Thank you very much.
Thank you.
All right, we have, Mark, two more speakers, Greg Moore of AFP and Ms. Chester, Ms. Rousson Chester. So just so the committee members know, I'm working on finding an alternative room for Hospital 1131. Haven't heard yet. We'll see what happens. I think my intention will be to, unless I get an answer in the next 5 minutes. Good morning again.
Good morning. My name is Rousson Chester. I am in support of this bill, and I just want to let you folks know that Dartmouth-Hitchcock spends $36,000 a month on that electric sign that tells you, step up and get vaccinated. It's a life or death decision. The fact that lobbyists are paid to be here, and those lobbyists are being paid actually with our tax dollars. Do you know Dartmouth-Hitchcock is now the largest employer in the state of New Hampshire? And I have been listening and listening to the lobbyists on behalf of our huge medical agencies. And the one thing I keep hearing is, well, it's not that we don't want competition. Oh, yes, it is. Oh, yes, it is. They are afraid that their lack of doing what is right for the people of this state will impact their financial position. This is an opportunity, and it's only going to happen in places that we have enough money to do it. For instance, Dartmouth-Hitchcock is partnering with CMC. That's a perfect example of what happened with Ma Bell. Why are we allowing Why are we allowing a healthcare agency, and I'm singling out Dartmouth-Hitchcock because I know a lot about it, but there's other large healthcare agencies too that own this state. And it's time to say no more. It's time to take our state back. The state was built on our backs, not on Dartmouth-Hitchcock's money, not on lobbyist money, not on politicians. It was built on us, and it's time to give it back to us. Thank you.
Questions of Ms. Chester? Seeing none, thank you very much. I believe that that is the last person signed up to speak on House Bill 1044, so I'm going to close the hearing. All right, this is what we're going to do. We're going to reopen the hearing on 11/31. Chief of Staff just told me that room 100 is likely to be available in about 15 to 20 minutes. When it's available, we'll move our proceedings across the street so that everybody in the public has an opportunity to be in the hearing. But given the tight time frames, I think we'll reopen the hearing on 11/31 and get through at least the elected officials, and I'm assuming there'll be some who've signed up to speak. Okay? All right, are there elected officials, are there reps that have signed up to speak? Yes. All right. We've already heard from the sponsor of the bill, Representative Weiler, so we'll go to Representative Knirk.
Sorry, who's next?
Yes.
Okay. Sorry. Thank you, Senator Bradley. Yes, for the record again, Representative Jerry Knirk, representing Carroll County District 3, and again also a retired spine surgeon. This bill did not come to HHSEA, it went to education. And as I come here today, I come here not to advocate just for either, saying yes, we have to have face masks or no, we don't, but rather to speak against the negative impact that 1131 has on the public health. At this point, I'm perfectly comfortable with kids not wearing masks in school. But that's not where I stood a year ago. And that's not because I'm confused, but because responses to public health must depend on the current situation.
Which ones did you say?
I'll just wait for a second, because it sounds like you guys are having a little conference work. Oh, that's true. Hot mic could be a problem. So, as an example, in Conway, the school board developed a reopening plan that was quite flexible. The question of mask use wasn't a yes or a no. It was flexible and based upon the current conditions at any given time. Now, the use of a face mask to prevent transmission of a respiratory disease is really a well-accepted public health measure that unfortunately has become politicized over the last couple of years. The best data we have supports the use of masks when necessary to prevent the transmission of respiratory diseases. Now, we saw an enormous amount of misinformation about mask wearing over the past 2 years. Some people have even blamed the educational losses in the past couple of years on the wearing of masks. But that kind of fails to take into account that there were a heck of a lot of other variables that went on in the last couple of years, such as loss of instruction due to schools being closed or children being quarantined, lack of access to virtual learning, difficulties at home due to a lack of supervision, and other events that occurred over these past 2 years. There have also been claims that masks are dangerous, and that claim was made during the bill introduction. And I've been batting that down a great deal. There are comments about it being dangerous due to carbon dioxide retention or lack of oxygen. And those are simply contradictory to known respiratory physiology. And there is absolutely no evidence of that, but there is clear evidence of the opposite, that it does not affect. And it's also common sense. I was a surgeon. I would wear a mask all day long, and I didn't suffer any ill effects, except perhaps the decision to become an elected representative, perhaps, I'm not sure. But in any case, so it's clearly, though, better not to require masks. I think, everybody's going to do better without a mask if they're not needed, but there are times that they might be needed, like we just went through with COVID. And you probably noticed a few weeks ago I wore one. Now I'm wearing one intermittently in this more crowded room. Now, the bill is presented, continues to talk about supporting individual choice about wearing masks. The difficulty is that when people come together in society, there's a social contract to respect the liberty of others as well. So Part 1, Article 3 of the Constitution, the New Hampshire Constitution, says, when men enter into a state of society, they surrender up some of their natural rights to that society in order to ensure the protection of others. And that's really what mask wearing has to do with. We do know that there is a modest effect in terms of protection of yourself. There's a better effect in terms of source control, which means you're controlling the source of the aerosol or droplets by catching them within the mask. So, and we also know 95, is it perfect? No, there's nothing we do. That's why we use layered mitigation strategies. So anyway, as an example, we say that you do not have the liberty to drive after drinking alcohol excessively, and we have that in place to protect others. That's a public health type of law. So anyway, the difficulty is that 1131 prohibits a school mandating of wearing a mask to control any respiratory illness, now and in the future. This blanket prohibition is wrong, because it's bad policy to place a prohibition of a potentially needed public health intervention into statute, as it ties the hands of our public health experts and our school boards, who need the flexibility to be able to respond in real time to communicable diseases. We don't know what's going to come at us in the future. HB 1131 prohibits mask wearing no matter what disease we're facing, no matter how bad the disease is, or what is recommended by public health experts. Statutes take time to change, but public health responses have to be nimble and not restricted by statute. It's for these reasons that I oppose this bill. I really do not think it should become law. I think it violates public health policy. Thank you, and I'll take any questions if you happen to have any.
Are there questions of Representative Knirk?
Sorry?
You'll have a chance, sir, to testify. It's
a question for me.
for committee members to ask questions. All right, seeing no questions. So,
thank you.
This is what we're going to do. We're going to recess this hearing for 5 minutes. We're going to go upstairs to room 201, 203, double room, and that will give everybody a chance to speak. And both of you as reps will get to go next, right? All right, I've got this. about all the confusion, folks. Thanks to the House and the Speaker for allowing us to use this room, and glad we're able to accommodate everybody. Go ahead, representatives.
Thank you, Mr. Chairman, members of the committee. For the record, I am Melissa Blasick, and I represent Hillsborough 21, the town of Merrimack. I just want to briefly say why this bill is still necessary. Despite DHHS updating their mask guidance and the subsequent lifting of many of the school mask mandates, there are still several reasons why this bill is relevant. First, there are several districts where children are still being forced to wear masks. And additionally, there are districts that have discussed implementing a mask mandate every winter moving forward for a standard cold and flu season. This is despite the fact that after 2 years, no one has been able to show conclusive evidence that we are helping the children, the teachers, or the community with these mandates without any harms being done to the children. And we do have Stephen Petty here today, he is an industrial hygienist and an expert in toxin exposure and mitigation, and he will be able to dive further into the science behind masking. But finally, the most crucial argument behind this bill is to get back to, as Governor Sununu has repeatedly stated, the old normal. This bill is the path back to the old normal for our children in schools. Thank you.
Hi, Representative Don Johnson, thank you for hearing us and everyone today. Representing Laconia, I just basically wanted to come up and support for this bill. I also sit on the Laconia School Board, and it's been a fight to get these masks off off the kids in our school district. We have seen, even in my own daughters, severe sinus infections and strep throat due to these masks. If we can take these masks off our kids, it would be so much better for them in order to breathe and not have to have all these other illnesses that have now come up with these mask mandates. Thank God we have now lifted the mask mandates in Laconia, but there's more schools that need this done, and we need to protect our kids.
Are there any questions? Seeing none. Thank you very much. Kelly Potenza.
So in a little bit, I just wanted to say that you will be receiving.
Ma'am, could identify yourself?
Oh, yes, my name is.
Thank you.
Yeah, Kelly Potenza, Rochester, New Hampshire citizen. There's a petition that was delivered to the House, and I just want to make sure that that is on record here. 5,311 people in the state. I am one of them. And this petition is to demand a ban on masking New Hampshire students. It needs to be parental choice. I just want that on the record. That petition will be delivered today, and that's from Rebuild New Hampshire. I'm sure you've all have heard the saying, if you repeat a lie often enough, people will believe it, and you will even come to believe it yourself. So Paul Joseph Goebbels was Hitler's propaganda minister in Nazi Germany, and that's someone that, there's many people that have said that over the years, about 80 years, but this is really key. One should not as a rule, reveal one's secrets, since one does not know if and when one may need them again. The essential English leadership secret does not depend on particular intelligence. Rather, it depends on remarkably stupid thick-headedness. The English follow the principle that when one lies, it should be a big lie, and one should stick to it. They keep up their lives, even at the risk of looking ridiculous. One of the people on this committee on April 15th of 2021 stated, "I urge the governor to rethink this unnecessary and potentially devastating deviation in our public health policy." That was letting the mask mandate basically retire. It's time to follow the science on masks. What does the latest science tell us? There's so much evidence that, we can just go on and on about it. But the Brownstone Institute, basically there's more than 150 comparative studies and articles on mask ineffectiveness and harms.
It demonstrates that they've had no impact on controlling transmission of COVID-19 and can actually be harmful. Is the mask that covers the nose and mouth free from undesirable side effects in everyday use and free of potential hazards? That's no. So basically, the study from the International Journal of Environmental Research and Public Health shows prolonged mask use is correlated with significant drops in oxygen, increase in carbon dioxide levels, fatigue, headaches, moisture buildup, temperature rise of the skin, and air under the mask, and respiratory impairment. We've had this information for so long, and it doesn't matter what science or studies or whatever we bring up, they're just falling on deaf ears. My rights have been infringed. My children's rights have been infringed. This has impacted me from the time that the governor shut down the state in March. We are all done. We are tired of testifying. I had to leave work, and this is, you've got all the people here. You knew there was gonna be a lot of people. There should have been a big room that was prepared for us. We don't have any patience anymore. It's not your choice, it's parental choice. And it's time to do the right thing. I would love this legislated and voted on immediately so it goes to the full Senate and this can get on the governor's desk because it has to be in law. Because people will do things like they have been doing without having the authority to do so. And that's why, as State Rep Blasek said, we have got to have this be a law. There's no more time. Let's get it done.
I would now recognize Stephen Petty. Good morning, sir.
First of all, I wanted to thank Melissa and the committee for the opportunity to talk. I've given you some handouts. I'm going to rapidly go through those, but I'll touch on the high points because I know there's limited time. Again, my name is Stephen Petty. I'm a certified industrial hygienist, certified safety professional, professional engineer. I've been working 45 years in the field of health and safety. Spent my entire life trying to protect workers and the public from toxins. I've sampled for anthrax, biotoxins, the whole list. I've been in over 400 cases named with respect to exposure control and exposure and PPE. And most recently, I testified in the state of Kentucky, and as a result of my testimony, the mask mandate was overturned statewide. So let me introduce the topic of industrial hygiene. Industrial hygiene is not well understood by many. We have a lot of physicians talking about industrial hygiene. It's not their field. Industrial hygiene is a science and art devoted to anticipation, recognition, evaluation, and control of environmental factors and stressors that can cause you to be sick, make you feel bad, or even kill you. And I've testified 400 times in those sorts of cases. The problem is that we have a lot of physicians talking about things like that, and they may be perfectly talented folks, but it's not their sandbox. When I'm in trials, we have a physician that talks about the disease, and I talk about exposure and exposure control and PPE. The physician that talked earlier, I'm here to show you that every statement he made is false. Let me go then. There's really 3 ways you can look at why masks can and cannot work, and I'm on page 3 of my handouts, the top slide. This is a plot of cases of COVID in New Hampshire with time. If you really believed that masks could work, you would expect the cases would drop with time. They do not. You can draw this plot for any state or any country in the world. What you see is where people are indoors more in the northern climates, the winter time, disease rates go up. That's a well understood industrial hygiene fact that's over 100 years old. And you see that in this plot. Now I want to move you on to the epidemiology, and there are lots of studies, but at the bottom of page 4, probably the one that's most relevant is the Bundgaard study out of Denmark. They looked at 6,000 or so folks, 3,000 with masks, 3,000 without masks. They found no difference in disease rate. Similar study was done on schools in Florida. same outcome, and that's on the bottom of page 5. The reality is that I testified in federal court in Michigan about the CDC studies and showed that almost all the studies they cited suffered from 2 flaws. One, they didn't have a control group, that is a group not wearing masks as similar to a group that was wearing masks to see what the differences were. If you don't have a control group, how do you know it makes a difference? The other thing is there were confounding factors where there were multiple things going on at the same time, with or without a control group, like air conditioning changes, separation, quarantine, and masking. There's no way to know whether masking has any effect at all. The real solution has always been, for 50 years, engineering controls of ventilation, dilution, or destruction. And those solutions I've actually implemented in real schools beginning in 2020. And I worked with many, many school districts to implement them. This isn't about a mask or a respirator. Those are the least desirable options. It's always about getting rid of the problem. Now let's look at this issue from a micro perspective real quickly. And again, I'm on the bottom of page 7. If you can see visible dust, it's on the order of 50 microns. That unit may or may not mean anything. The virus is 500 times smaller than what you can see. If you look at a cross-section of a human hair, I've got a plot on the bottom of page 7. You see that dot. That dot is 10 times the size of a virus. It's a micron or so. So the COVID particle is 1,000 times smaller than the cross-section of human hair. And I ask everybody the simple question. You wear your mask, can you slip a human hair by the side of your mask? Of course you can, especially below the eyes. It's a super freeway for the virus to come and go. This source control argument is bogus. Source control means the person wearing the mask somehow or other, those viruses can't escape the mask. That's just nonsense. If you've got this super freeway, the virus doesn't care where it's coming in or going out. A couple of things that need to be talked about real quickly. There's been great disinformation about COVID being a droplet. Now, particles can be classified in 2 bins, droplets and aerosols. The data I show on page 8 shows that over 99.9% of the particles are aerosols, less than 5 microns. They're not droplets. That's not the problem. The other thing that you see on the bottom is droplets fall to the ground very quickly. So even though they're a very small fraction, they'll fall to the ground on the order of minutes. If you look on the top of page 9, though, and you look at aerosols, it takes up to 50 days for them to fall. So these things are suspended in the air for days and days. So there's no way you have a COVID meter on your chest or your head. The only way that you're going to know if somebody's in aisle 4 and is sick the day before, you have no way of knowing whether that stuff's still there or not. So what's the solution? The solution is to dilute it with ventilation, filter it out, or destroy it. It always has been the solution. The National Safety Council gave us those solutions from an industrial hygiene standpoint in 1950, over 70 years ago. People talk about these masks. Why can masks not work? Bottom of page 9. The problem is you cannot seal a mask by definition. A mask that seals is a respirator. I also want to talk a little bit, they say, well, I'm now on page 11. I want to whip through this. They say, well, they might do a little bit of good. Well, that isn't in industrial hygiene, we don't look at solutions that do a little bit of good. It might help 1% of the people. We have a requirement that if we're going to provide a solution that helps the public, it better have at least a 90% relative risk reduction. So how would you feel if I walked in and I said to asbestos workers, let's put you in a mask, it might save 1% of you from asbestosis, but the other 99% will get it. I think I would lose all my licenses. And by the way, the asbestos fiber on average is 50 times larger than a COVID particle, and we have very high-end respirators, PAPRs, that are used to protect asbestos workers. And I'm certified in protecting asbestos workers. So why in the world would you take a 1% solution when you need 90% when we have solutions like ventilation destruction and filtration that do meet that 90% requirement from industrial hygiene? The other thing you hear about all the time is on page 12, you see the top. Well, let's move on to N95s. As I just said, we wouldn't even use an N95 for asbestos workers. But here's a study by Shaw et al. That shows even for an N95 where you glue it onto a board, and that's where most of these mask studies are done. They literally glue the mask onto a mannequin or a board. Now, do you glue your mask on your face? Of course not. So what happens when it's not? So if it's glued on, they say, well, it has 46% effectiveness. But what if you put a gap on it? 3% effectiveness. And that's the real world. So about masks, on to page 13. On January 2nd, 2022, Scott Gottlieb, FDA commissioner and Face the Nation, spilled the beans. He said basically masks don't work. I've been putting real engineering controls in real schools for 2 years. You can imagine, as somebody who spent his whole life defending workers in toxic tort trials and the public, how infuriating it is to see people propose solutions that cannot and do not work. He admitted it. We also had CDC finally admit on January 14th of 2022, well, these masks aren't very effective, so let's move to N95s. I've said, no, let's move to engineering controls. If you follow the CDC guidance, I said, what science changes its position 180 degrees in 2 years? Mask, no mask, mask, no mask. No science does that. The other thing I want to point out is on the bottom of page 15, and I wrote a 27-page letter to CDC in February complaining about this, as well as to Fauci in the White House, along with 8 other industrial hygiene folks. They say, well, we want to put children in N95s, and then they link you to the manufacturers' websites, including 3M. What does 3M say about N95s in children? Not designated to be used by children. And also they say, well, as soon as you go to masks, you got to start following respiratory protection standard, which has all sorts of requirements. You can't just hand somebody an N95 and not incur a lot of liability if you don't ensure that they're fit tested, that they're medically cleared to wear it, that they've been trained on how to wear it, and they've been trained on how to replace it. So on the bottom of page 16, we have industrial hygiene, as I've said before, what we call the hierarchy of controls. Everybody agrees with this. The most effective hierarchy is engineering controls. The least effective would be personal protective equipment, or PPE. And PPE for respiratory protection is respirators, because you can seal respirators. Now, why are respirators on the bottom of the barrel for controlling hazards? Because they don't get worn right. You put somebody in, we know this from decades of doing this. You put a respirator on somebody for 8 hours a day, they're going to break that seal. Guaranteed, it's not going to get worn right. Well, the interesting thing is masks don't even fit in the hierarchy. They're below it. They're not even part of it. Again, engineering controls is the solution. Now, what about damage to children? There's lots and lots of data on this. Beginning on page 18, Curriculum Associates is showing both for reading and for mathematics in 1 year loss of performance of upwards of 12 to 15%, depending on the grade level. And it's worse for minorities, as you see on page 19. Brown University put a study out for kids born during COVID wearing masks, show a 23% reduction in learning. So what did CDC do on February 8th? They took the 18-year-old criteria for child development and they moved the goalpost. They didn't admit that this was causing enormous damage. They said, okay, the performance standards you have at 24 months, we're going to make 30 months. Sad. Also, the England Department of Education, I'm on the bottom of 20, noted that 94% of the teachers indicated that wearing face coverings has made communication more difficult, and 59% said much more difficult. Kuzlensky and their co-authors looked at 1,226 papers on masking, distilled it down to 109 qualitative and 49 quantitative, bottom of page 21. And they showed 27 adverse effects they could quantitate, including 5 specifically for children. So what's my answer and conclusion for all of you? Please put this in place. Masks have not ever been and cannot be a solution. Engineering controls of fresh air, filtration, destruction have and always will be the best solutions. We don't have to worry, as the physician said earlier, about some future pandemic, because the right solutions will always be engineering controls. They have been for 80 years. Thank you.
Questions? Senator Avard.
Thank you, Mr. Chair, and thank you for your testimony. I'm just curious, is all this information available on Google, and have you been contacted by the media, whether Channel 9 or Fox News, to disperse this information because it seems to be new?
The answer is it's not new. I have given 6 national podcast statements that are online. Our presentations of this material beginning in 2020, after I did the school in Ohio with 750 autistic children. The material, I spent almost $500,000 of my own time and money building a studio and putting out 20 podcasts summarizing all this. Each podcast, any study I cite will have the URL or the reference to the material. It is true more material is coming out with time, but the underlying industrial hygiene, it's a field not well understood, but the underlying premises of industrial hygiene have been in place since 1950, which is engineering controls.
Any further questions? This is some of the most compelling testimony that I think this committee has heard, and Mr. Petty, we thank you. Representative Blazek, would you work with, or perhaps you can just get your resume to the committee so that if we have any further questions, we can reach out to you independently? Is that okay?
Absolutely. I provided it to almost 100 litigation in the United States already, so I'd be glad to do that. Thank you for the time.
Yeah, thank you, sir. Thank you. Okay, so are there any other elected officials that I haven't recognized that wish to speak at this point in time? Okay. I'm going to do my best to go through the list that I have in front of me. And I'm going to start with Carla Smith. I'll try to do it without the time limit.
Hello, my name is Carla Smith. I'm a registered nurse in New Hampshire, and I'm here today representing the New Hampshire Nurses Association. I have handouts that I will pass around, and I'm just going to read an excerpt from you here. Historically, local schools have had the right to control policies for their employees and students to protect the health and safety of those same individuals who utilize their services. If all school boards were prevented from establishing reliable, science-based mitigation policies, employees and students would not be able to reliably know that they will be protected from exposure. School boards should not be prohibited from requiring masks in times when they are necessary to ensure the health and safety of those they serve. Restricting evidence-based strategies significantly inhibits those boards' ability to maintain a safe school environment, while putting vulnerable and immune-compromised students at risk. The New Hampshire Nurses Association urges you to oppose House Bill 1131 and continue to give local control to school boards, including the right to establish requirements for their own students and employees to protect the health and safety of those same individuals and all who utilize their facilities. On a separate note, I am a mother. I have 3 children. My youngest does attend public school. She has high COVID rates in her school. They have mask optional policies. In my professional world, I am a professor at a private university here in New Hampshire. We have 3 campuses, Manchester and 2 in Massachusetts, 1 in Worcester, 1 in Boston. Our positivity rate for our school since we returned to campus in fall of 2020 is 0.7%, less than 1% rate. That is not a published study. That is data that is collected internally. We use the Broad School at MIT performs our testing and collects our data. In a quantitative world of research, it is 100% probability sampling because we adhere 100% to testing in a mask use to be on campus. Less than 1%. I can tell you it works. I've lived it. I've been living this for 2 years. Just want to say, again, I'm here representing the Nurses Association. I know you have a lot of opposition, a lot of support, I should say, in the room. I think I'm the minority speaking who's opposed to this bill, but I do hope that you consider what the nurses in New Hampshire feel. Thank you.
Thank you very much. Seeing no questions. Julie Smith. Good morning, ma'am.
Good afternoon, committee. Julie Smith from Nashua. I support this bill. I'd like to thank our distinguished expert for coming back for a second testimony, and as a cat person myself, reminding the Senate committee that mask effectiveness is his sandbox, not the medical field's. Since time is limited, I will skip over the part about public schools being taxpayer-funded child abuse. That's already been established. I want to address the private school part of it. I have the pleasure of knowing 2 people whose kids have attended school with 1 or more of New Hampshire's first kids. One of them expressed her frustration to me last summer about their school's failure, or should I say refusal, to commit to a firm and unwavering mask policy before tuition payment was due for the next academic year. As a consumer, which is what private school parents are, wouldn't you want clear terms spelled out to you before signing a contract for any big ticket goods or services? Private school tuition being a big ticket service. This bill prevents the parental rights of ordinary private citizens from being trampled on by other parents that just happen to be in office at the time or in other positions of influence. I want this bill to pass, and I know how my senator will vote. It's very unfortunate how the doctor and lawyer are expected to vote. My message to the committee leadership is a civics reminder to everyone. The chair of any committee, House or Senate, works for me and my ordinary people peers. Not lobbyists, not big donors, and certainly not the governor. I've watched the Senate live streaming lately, and I must say that I've been very disappointed by several fake Republicans. Please do better. Repent and vote correctly. Thank you for the time.
Allison Dwyer. Good morning.
Good afternoon. I'm Allison Dyer, Nashua, New Hampshire. I'm in support of this bill, HB 1131. To steal a line from Melissa, Rep. Melissa Blasek, as a parent, your first call of duty is to protect your child, not light your child on fire to keep other children warm. Any child who wants to wear a mask should be free to do so, but forcing them to make personal health and developmental sacrifices for the sake of fear-laden adults is abusive. It's not that masks don't work, it's that they're not perfect and they don't suppress the infection. And where we fail in our public health policy has been in what we do once people get infected. There seems to be a false choice between public health and individual freedom here. We have accepted this as binary, and that has invited politicians to politicize it. Public health, in other words, is inconsistent with the right to be left alone. Of all the risk factors for disease or injury, it would seem now today that freedom is the most pernicious. Why the continued push for mask mandates for healthy people? Many scientific studies and analysis all arrive at the same conclusion. The wearing of masks by healthy people cannot stop the spread of a virus. People without any symptoms tested and have a positive PCR test due to the presence of non-viable RNA rarely spread the virus. The most important magic rule is the ancestral wisdom of stay home, rest, hydrate, wash your hands, and strengthen your immune system with healthy food and lifestyle. It will decrease the risk for infections and chronic diseases. I have also submitted testimony via email to you and about 250 studies from masks, including Dr. Petty's testimony. I'm asking you to vote yes for this bill to restore our parental, not political right to choose. My child, my choice. Thank you.
Karen Rosenberg. And followed by Maureen Hardy.
Good afternoon. I'm Karen Rosenberg. I'm with the Disability Rights Center. I'm here to testify in opposition to HB 1131. And very briefly, from the perspective of a disability rights organization, I'm concerned about kids who have significant medical issues, complex medical needs, other kinds of disabilities that may make them particularly vulnerable to this kind of virus or some other infection. And it may be that these children, in order to have equal access to educational opportunities, require people around them to wear masks, not just for them to wear masks, or may require other kinds of accommodations, such as distancing or other kinds of accommodations. But to have a blanket policy that says this can never happen, even though a medical professional may determine that a child requires people around that child to be masked, I think is really a disservice to kids with disabilities. And to then put a person's license on the line, a teacher's license on the line, if they were to accommodate a disability or subject a person to financial hardship and having to fight a civil lawsuit, is just would be very, very unfortunate. Just when the object here is to protect equal access for kids with disabilities who want to attend our public schools. So thank you for your attention. I know you're going to have a long day ahead of you.
Thank you. Maureen Hardy, and followed by Nicole Sousa.
Hello, thank you for hearing my testimony today. My name is Maureen Hardy from Londonderry, New Hampshire, and I am testifying in favor of this bill. I've worked in the clinical microbiology lab for 26 years, participated in the infection control task group for my hospital, including ambulatory care settings. I have worked in research and development for diagnostic devices and have worked in the pharmaceutical industry and pharmacovigilance. I have taught clinical microbiology at the community college level and medical ethics at the university level. I have a master's degree in epidemiology. When evaluating a mitigation strategy for a disease, whether it be from the perspective of a pharmaceutical product or a public health policy, the risk-benefit analysis must be considered. Based on multiple studies and population data, the risk-benefit analysis does not support the use of facial masks for the prevention of COVID-19, especially for children. The wearing of facial masks does not prevent the transmission of respiratory viruses, for example, SARS-CoV-2. I have included a number of studies emailed to all of you that you can click on all the links and read the studies. Children are at extremely low risk of bad outcomes from the infection, and wearing masks is not a benign intervention and causes serious and potentially long-term damage to children. Wearing masks causes physical, psychological, and social damage to children. We also know that masks encourage mouth breathing in children, which leads to facial deformities. Masks interfere with children learning socially through facial expressions. Speech learning is lost in the very young. Learning deficits have been observed in all. An Israeli-Canadian study published in Cognitive Research in February 2022 found that face masks disrupt holistic processing and face perception in school-age children. Masks keep other pathogens that are larger trapped near the mouth and nose and in the lungs of the children. These are larger pathogens and include bacteria, mold, and parasites. Finally, children need to be free to be exposed to the natural environment to keep their immune system strong. Therefore, the risk-benefit analysis does not support the use of facial masks as public health mitigation strategy, especially for school children. There is zero benefit and high risk. The mask recommendations were put into place by national and local public health agencies without evidence of benefit and without evaluation of risks, and followed by school boards and administrators who had no other source of guidance. We now have 20/20 hindsight and understand that masking children is wrong. Let us correct this now and not put the school boards in the position of having to mandate bad policy ever again. There is fear among some of a more lethal virus arriving around the world, but the spread of another respiratory virus also would not be mitigated by mask wearing. I wish that it would work, but unfortunately it does not. Thank you for listening. Does anyone have any questions?
One.
Senator
Thank you.
Avard.
You said that larger pathogens get trapped behind the mask, such as mold. What were the other ones?
Parasites and bacteria.
Thank you.
Thank you very much, Ms. Hardy. Nicole Sousa, followed by Deborah House.
Hi, my name is Nicole Souza, and I'm from Amherst. Did you know that there isn't a single randomized controlled trial on child masking in schools? That's the highest quality evidence, not a single one. The burden should be on the intervention to prove that it's safe and effective, not on us to prove that it's harm. Why are we forcing an untested medical intervention on our children without known benefit and without parental consent? That's what we're doing. It's an experiment. The US is an outlier when it comes to masking children. We are the rare place that actually masks under 6. Most countries do not mask under 12. And there are European countries that never masked any children. Their COVID outcomes in school are no worse than ours, and they do not have the harms that we see, like severe learning loss and mental health crisis. I wish this bill wasn't necessary, that we didn't already have metrics in place when our children are the least at risk from COVID and the most at risk from harms, but they are. Sorry. I'd like to share with you some comments from children after their school went mask optional. I can hear my teacher. It's so much easier to hear my friends. My friend is so pretty. One parent commented that just 2 days of mask optional, her 6-year-old made her first friend. This was after 6 months of school. Children cried and jumped with happiness when they found out that they could remove their masks. Smiles radiated from the school grounds. Children saw their teachers' faces for the first time, and some of them didn't even recognize them. Our children have been forced into an experiment, and we are just beginning to understand the harms. I would like to also talk about disabled kids that are not represented by the ADA. There are children that have hard of hearing and that are deaf, and the world to them has become completely mute. There are also children that are on IEP that have severe social and emotional deficiencies, and that wearing a mask has made their school environment agonizing, as has caused severe degradation in their learning and their emotional. So parents have noted a significant effect. and they have cried at school board meetings, and nobody is listening because the ADA will not represent them. It's time to stop experimenting on our children without parental consent. It's time to let our children heal. It's time to stop the school board fights in the community. Follow the lead of many European countries and US states around the world, and stop allowing people to force masks on our children without our consent. If you want to force masks on, you better have high quality evidence, and we have none, and all the high quality evidence says they do not prevent the transmission of any respiratory viruses. And we know this, 100 years of studies on the flu. So I would urge you to please stand up for our children and support this bill and consider private schools, please. Thank you.
Ms. Howes, followed by Teresa Grinnell.
Okay, let's see. Okay. Good morning, Senator Bradley. My name is Deborah House. I am president of AFT New Hampshire, and it's my first time addressing the Senate Health and Human Services Committee.
So if
I
you could
appreciate you
please
taking my
summarize
testimony.
rather than read
I will
your
summarize. I
testimony.
will not
Perfect.
read.
Thank
So
you.
I have 3 quick points I want to make. The first is that I'm here representing 3,500 members of AFT New Hampshire, and we are opposing this bill. We do not want to take away an effective tool in the layered measure of mitigation of COVID or any other airborne contagious virus. We want to see schools remain open. We want to see our students in person. We want to be able to teach our students. We feel that this is a matter of local control. Local school boards know best what local conditions are. One size fits all mandate prohibiting it across the state is not a good idea. You may have high numbers in one community and low numbers in another. Local school boards need to be able to react to what's happening locally. And the third point I want to make is that it is absolutely inappropriate to have a provision in this bill that would penalize teachers for enforcing a policy that a local school board makes. Teachers are responsible for carrying out the policies of local school boards. If they don't, they can be fired. So now you want to pass a law that says you can be penalized and lose your license if you do enforce a policy of a local school board? That's ridiculous. So we find this bill inexpedient to legislate, and we urge you to do the same. Thank you.
Questions? Thank you very much. Seeing none.
Okay.
Teresa Grinnell, followed by Walter Kirsch.
Thank you, Senator Bradley. My name is Teresa Grinnell. I'm from Loudon, New Hampshire. I'm also a registered nurse, and I adopted my 2 boys from foster care. I have a 6- and 7-year-old, both developmentally delayed. Both of them struggle with an IEP. Brett, my 7-year-old, this is where my Liberty journey actually began last year. My 7-year-old, he would chew on his mask. His mask would be sopping wet. I went to Sam's Club. I bought the disposables. Swap it out, please, please, please. The teachers weren't able to facilitate that. He would come home. It was filthy. As a nurse, as I'm sure Dr. Sherman can attest to, we see orders that are CDI, clean, dry, and intact, right, when we do a wound. My nursing career taught me that you do not keep something that is sopping wet, that is warm, moist, in a dark area to harbor bacteria in a wound without potentially creating infection. This child was getting so many mask reminders that he started flapping, to the point that this child, when he's introduced to someone, says, "I'm a flapper." And people say, "What, you fart?" No. I get excited and I flap. I had to pull him out of public school. This is a child who needed normalcy. This is a child who's gone through so much trauma in his story. This is a child who thrives at school. He loves his teachers. I had to pull him out because it became so hard for him, and I could not get a provider to give him medical clearance because the providers were saying that they were being threatened that they would be under investigation if they did an exemption. The ADA did not support him. I was a nurse who was trying to move people out of the ICU and get them appropriately discharged to the next step level of care. I had to bring these two boys home, one who was left in his car seat for the first 4 years of his life, who had no speech when he came to me. He is 6. He is still struggling. The masking really impacted these two children that I've been charged to raise up and protect. We have a governor that goes onto social media that says the children were never masked in New Hampshire. I don't know how our elected can leave it to school board moms, people who don't have a medical background, and wash their hands and by proxy make decisions that take away parental rights. I'm begging you for the constituents here in New Hampshire. We need to allow parents to parent and make the decisions that are right for their children. These cloth masks that are bought at the dollar store, that are thrown in backpacks, that don't get washed, that are filthy dirty. My dad, he said, T, if you're not gonna do something right, don't do it at all. We have done it the wrong way for the sake of saying we're doing something. I understand COVID was scary, but our children, to force it on them when they're trying to learn, and then you turn around and that same school board member's out in public with their children with no mask, or on school orientation day, I get all these pictures sent to me at Merrimack Valley School District of the nurses and all the faculty and all the staff without a mask, but that following day when school started, my 6 and 7-year-old would need to wear a mask. Are we teaching our children that we're doing something because it's truly effective, or are we teaching them just to do something to say that we're doing it? It became so political. That was the beginning of my journey to stand up and say, what is going on here? You don't keep a sopping wet dressing on a wound. You would have my head if I was your nurse and you walked in and your patient had a sopping wet dressing on their fresh surgical wound. That's how my child was coming home. Please, let's leave interventions that are medical truly to medical directors versus school boards. Let's leave parental rights to parents. If someone doesn't feel good, if their child's immune compromised, if they need to mask and have things to protect them, this community will rally around protecting that child. But that doesn't mean every single child in that school is going to run around with a dirty, infested mask on their face. It makes no sense. If we're going to do something, let's do it the right way. Let's not just do it for the sake of doing it, knowing that we're harming so many. Thank you for your time. I support this bill.
Mr. Kirsch, followed by, I believe it's a Ms. Kirsch.
Yes, thank you for hearing me. My name is Walter Kirsch. I'm representing all free-thinking American people who have some common sense. Pretty obvious these masks are more detriment than any health benefits, and everything just seems so politically motivated now. This seems like it's a political game with the left and the right, and I'm sick of partisan politics. This bill, we need to pass it. I mean, let's take partisan politics out of our health choices and end this mandate and all other mandates. That's all I got. Thank you.
Thank you. I think, if I read it correctly, Doris Kirsch?
Dorcas Kirsch, yes.
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 Good morning.
Hi, good morning. Oh, I'll keep it simple and quick. So, oxygen is pretty essential to living. It's to restrict it is kind of foolish. I go by. I've got a Holy Bible at home. I read it. I know what it says. In the book of Deuteronomy, talks about the blessing and curses that God has says that will be given over to the madness. And it seems like there's a madness going on in this world right now. Just got a few. It is better to trust in the Lord than to put confidence in men. That's Psalm 118:8. And the Lord God formed man of the dust of the ground and breathed into his nostrils the breath of life, and man became a living soul. Genesis 2:7. All the while my breath is in me, and the Spirit of God is in my nostrils. Job 27:3. And where the Spirit of the Lord is, there is liberty. 2 Corinthians 3:17b. We're all going to die at some point, and it seems like we've trying to pretend like it's not going to happen. Sicknesses come. God has put, we have immune systems. And I just pray that people will use their God-given logic to answer this. And I think I'm voting yes, right? Yes, and it's a yes. God, I don't know if there's any questions.
Thank you very much, ma'am.
Thank you.
Rachel Goldsmith, followed by Gina Nessig, I believe. Good morning, ma'am.
Hi, Rachel Goldsmith, New Hampshire resident in Manchester, New Hampshire, and also the chair of the Hillsborough County of Moms for Liberty. We don't expect teachers to remind kids to take their vitamins. We don't expect teachers to prescribe psychiatric medicine. And we can't expect teachers to enforce virus prevention measures. That is not something that they should be doing. They should be teaching reading, writing, and arithmetic. When I think about the test scores that we're seeing out of public schools in the last 2 years, even the last 5 or 10 years, they're on decline. Teachers are not able to focus on the task at hand because they have too many other things to think about. And enforcing a mask mandate on potentially kids with disabilities, IEPs, there's too much variation for them to have to think about. We have a number of members who have come to us and said that they have an IEP from their actual physician, from their pediatrician, saying that their kid, for whatever reason, it could be because they had brain surgery and they can't wear a mask. It could be that they have some type of anxiety disorder and they can't wear a mask. These IEPs are not being enforced by teachers because they're too busy following their school board's mandates. School boards are not doctors. Please allow families to choose their own risk levels. Please allow families to choose what their children's medical needs are. So I'm in support of this bill. Thank you.
Thank you very much. Gina Nessig, I believe, followed by Joanna Brown. And if any of the youngsters would like to sit in the chairs, if they choose to do that, feel free. The back row is fine. Good morning.
Good morning. I'm Gina Neely, and I'm from Epsom, New Hampshire.
Well, they can testify too. I mean, that's fine.
I'm a school bus driver, and I've been transporting students for nearly 10 years. I'm here today to share what I have observed over the last 2 years. I drive a high school run that brings Deerfield students to Concord High School. I pick up my first student at 6 a.m. After spending the day at school, these students are transported back home and get home anywhere between 4 and 4:30. Up until recently, these students were required to wear a mask while on the bus. Concord High School also required the students to wear masks not only in school, but on the campus as well. There has been ample testimony regarding the efficacy of these masks and how there is an over 99% survival rate for our children. And yet, we force these students to wear masks for over 10 hours a day. I lost my spot. In June of last year, while masks were mandatory, we had some very warm days. The school actually decided to release the students early one day because the temperatures had risen so high. Out of curiosity, I had brought a thermometer onto the bus because I wanted to see just how hot it was, because it's always hotter on the bus. it was 104 degrees, and I was expected to have these kids in masks on the bus. I couldn't do it. I was not going to enforce that because it's dangerous. I brought popsicles instead because I was just using common sense. I also drive an elementary run after my high school run, and I pick up kids that are from kindergarten to 8th grade. And prior to COVID, I would be driving the bus with all these students, and I'd be admonishing them to stay in their seats and to lower their voices because they'd be so loud, and you have to concentrate while you're driving. And now, since the masks, my bus is silent. I don't even see my students on my bus. They don't move around, they don't talk, they don't laugh. It's silent, and it breaks my heart. So 6 weeks ago, these kids were allowed to remove their masks. And I thought, yay, I get to see their faces. I get to see them, laughing and enjoying their ride. And they're still silent. It is taking so long to draw these kids out. So I definitely support this bill. I think that it should be a parent's choice whether a child is masked or not masked. And when the masks aren't even effective, I just don't understand what we're doing. So thank you. Thank you for your time.
Thank you very much. Joanna Brown, good morning, followed by John Chamberlain.
Good morning, I'm Joanna Brown from Manchester, New Hampshire. I think you've heard enough that masks don't work, but I'm here to tell you that they do harm. I have 3 teenagers in the Manchester high school system. But let's start at the beginning. Facial cues and visual expressions are part of body language that children learn at a very young age. Reading lips is an integral part of speech development for young children, but it's also for the hearing impaired. And constant mask wearing interrupts interpersonal relations for older children as well. Masks cause anxiety for teenagers, even teenagers that are not on IEPs, because they can't tell whether someone's smiling at them or frowning at them. And there was a great deal of anxiety stemming from the fear-mongering coming from the teachers. One teacher who actually stated that a student was going to kill their elderly mother because a student didn't wear a mask properly. This kind of stress that is coming through the school system, that's coming through the school boards, that's coming through the state, is doing psychological damage to our children. Masks caused increased fear and sadness, especially in teens who are dealing with powerful emotions about life, never returning to normal. A nurse who spoke at a recent school board meeting in Manchester told us that she's a nurse, works in the emergency room. She saw a huge spike in troubled teens coming in with suicide attempts and severe depression. At the Manchester schools where my kids attend, there is a tremendous increase in aggression, especially amongst the freshman students. These kids have had 2 years of fear and anxiety that has done long-term damage. We don't know where it's going from here, but we need to stop things that aren't helping. Masks don't help stop COVID. They don't. They were never intended to. This is a parental decision, not a state or a school board decision. That's all I really have to say. Thank you.
Thank you. John Chamberlain, followed by Christine Vignal. Good morning, sir.
Good morning.
Actually, good afternoon.
Yeah. My name is John Chamberlain. I'm a resident of, and recently was an elected official in Newington, New Hampshire. I'm speaking in support of 1131. I have provided 5 pieces of evidence to the board. It's all in your inbox, and it also has been mailed to the clerk. So I'll just briefly highlight a couple of the points, and I'll leave the rest for your review later. The first point I wanted to emphasize is a repetition of what you've already heard today, that objective scientific research has concluded that masks do not work. Although there are certainly politically motivated statistical studies alleging that masks have a beneficial effect, most objective studies have consistently concluded that masks don't work. Attached is a full scientific review published in Emerging Infectious Diseases, an authoritative journal. This is the #1 journal in epidemiology, is the Emerging Infectious Diseases journal. In May of 2020, at the height of the pandemic, the journal published a review study by the top epidemiologists in the world. A review study is a study that looks at all of the evidence over history, over like 100 years, like every piece of evidence. That's what a review study does. This was published in May of 2020. It's in your inbox. I'm going to quote the conclusion from the abstract of that paper. In this review, we did not find evidence to support a protective effect of personal protective measures or environmental measures in reducing influenza transmission. I don't see how that could be any more clear that masks don't work. I'm also going to briefly highlight point number 4 of my evidentiary submission, and that is that masks harm emotional development in children, which you've already heard today. And my contribution is a specific study, which was very comprehensive, an evidentiary-based study that documents this. The study by Gori et al., I'll read from the abstract. A mask obstructing a face limits the ability of people of all ages to infer emotions expressed by facial features, but the difficulties associated with the mask's use are significantly pronounced in children's aged between 3 and 5 years old. So this was a comprehensive experimental study by expert psychologists validating what you've already heard today. Once again, it's in your inbox, and I encourage you to read it. Thank you.
Thank you, sir. Christine Vignol, followed by Rusan Chester again.
Good afternoon. All right, come on over here, buddy. You got this. My name's Christine Vigneault. I live here in Concord with my husband and my 2 sons. This is William, and I have a 3rd grader, Colin. And I'm here in support of this bill. I took both of my children out of the public school system immediately after I heard that there would be forced masks on my children. I felt like the majority of people understand now, 106 weeks later, that masks in an uncontrolled public setting do absolutely nothing to mitigate the virus. And more importantly, that masks on children do nothing but cause harm. I've seen it in some children, and it's heartbreaking. They've been terrorized and are petrified now without their masks. Is that not child abuse? What have these mandates done to these poor children? We don't even know the half of it, and we should be ashamed. Fauci knew they never worked. Why he pushed for compliance so callously has yet to be determined. OSHA, the industrial hygienists, knew masks in this context were a total farce and incredibly harmful. They had decades of data proving it. The brave ones tried to speak out against mass masking very early on, but surprise, they were censored and threatened. These are the PPE experts, the ones that teach doctors how to properly don and doff their masks. No one understands viral contamination like an industrial hygienist, as we heard earlier. Why were these people silenced? This can never be allowed to happen again. We know they don't work. We know the children suffer behind them. We know they make viral spread worse through fomite transmission, which is cross-contamination, and by weakening the immune system. My husband is a physical therapist in a skilled nursing facility in town and wears an N95 day in and day out, as does everybody else in the building. Not surprisingly, viruses of all kinds pass through like wildfire, because when you're dealing with infectious disease, not even an N95 is fully rated to protect against a virus. On just one floor, not too long ago, out of 70 patients, 50 were COVID positive. All were vaccinated and all wore masks during all interactions. He's come home every single day for the past 2 years with headaches and intense fatigue, which are just the short-term effects. The long-term effects are much worse. We've all been abused. We've been psychologically manipulated from the very beginning. We've been put in a trance, coaxed to live in fear, hypnotized by the news. with its sensational 24/7 virus coverage, with its distorted numbers and pharma-funded news anchors and pundits. Some were immune to the manipulation, others fell for it full on. I'm trying to find grace and understanding of those who still insist to live behind masks, but what boils my blood is to see the children still behind them, and to know that there are adults who want children in masks for their own comfort. They can't stand up for themselves, and it's rare even for a teenager to stand apart from the crowd. Peer pressure is alive and well, and we've been masterfully conditioned. The mask was a powerful signal of virtue for some, but for us, it's seen as a gag, a dirty rag, and a useless security blanket at best. Let's show the country that New Hampshire has retained its common sense, despite this roller coaster of lunacy we've been stuck on. Despite the circus we've been forced to watch, it's all been a show. Let's please support this bill. Thank you.
William, do you have anything to add?
Sorry about that.
Nothing? Wow. I'll give you a second chance, William. Ms. Chester. Followed by Nicole Nordlund.
Thank you, committee chair. Thank you, committee members. I just want to take this opportunity to let you folks know that I really appreciate that you made the decision to move this to a larger room, and it was not. It does make an impact. You've heard a lot of people speak today about the masks. I am coming from a little different point because I worked in child abuse and neglect for 17 years, and then I went from there to adult and elderly neglect in another state. I worked in those areas during the initial HIV thing, and anyone that came in contact with anyone that was HIV positive it was a death sentence. I worked through that. I refused to do the kind of masking and PPE stuff that they advocated that I do. I was a social worker. I went into their homes. Being masked is not human. Taking people's faces away from them is a crime against the humanities. And if you look at the DSM-5, or DSM-4 and 5, you will find reactive attachment disorder, PTSD, victims of violence, children that have been abused, suffer from all these things. And a lot of times it stems from the lack of trust. They can't trust their own senses. Why? Because they don't know what's coming next. And why is that? A lot of times, children, infants, when they cry, if they are comforted and you see their face and they know what's going on, that gives them the sense of security. By masking our children, we've taken that away from them. And it's a travesty. It's an absolute travesty that we've done this. We've chosen to appeal to the lobbyists and the school board. We talk about the school board. We talk about DRC. We talk about NAMI New Hampshire. All those agencies were dealing with this before COVID. Why would it have to be different now? Why does now, we have to be careful for the other children? So it's like no child left behind. We're just going to put them all in, and most of the children will be left behind except for. There's a bus driver that I work with. She really brought it up to me. One of the problems with masking children on the bus is those children are getting on and off the bus, young children, and being taken by whoever picks them up. Do you know how huge a risk that is? Just how easy would it be for a non-custodial parent to pick up a child at a bus stop when there's a mask? These bus drivers have never seen their children. They've never seen their faces. They don't know the name. They don't know their parents. We have put all of our families in a position where we have chosen to abuse our children to appease the fearful. When did it become our children's job to do that? It should not be our children's job. I started a program when I first started coming here to testify, where people can call into a phone number, and when they call that phone number, they are completely anonymous because the number that comes up is the number they called. In less than 10 days, I have gotten calls from 183 people working in the school systems that want this, that support this. These are people that are working in the school systems, that are working in nursing capacity, cafeteria capacity, teaching capacity, that want this in less than 10 days. They're not willing to come here and talk because they're worried that they will be held accountable and responsible from their school boards, from their unions. It's not okay. We need to start standing up for the people in New Hampshire and our children. Look around. Look around at the children's faces. Now, think about that when their faces are taken away. Thank you.
Thank you very much. Nicole, followed by Victoria Gula. Good afternoon.
Good afternoon. I'm speaking in support of HB 1131. I am also more specifically speaking in support of leaving it alone and not changing it in any way and keeping it, supporting it as written. I didn't plan on speaking. I was really just going to sign up to speak to ask you to change venues, which, you know, you did, but so I want to thank you. Like many in the room, I wear a few hats. I'm a mom. I'm the wife of a veteran school teacher of 20 years, and I'm also a foster mom. I also have an adopted child through the state, and I can attest to everything that Therese and others have said is 100% accurate, as I spent years studying attachment disorder and trust in children. Basically, I was wondering if anybody here caught any of the education committee meeting, the House Education Committee meeting, because I played it at work by myself, and I was moved to tears. That was the meeting that took place during the snowstorm, and it was packed. People came from all corners of the state in a snowstorm. I believe it was the only meeting that day that was not rescheduled. It was heart-wrenching to hear those stories. Parent after parent testifying that although we were being told that all of this was temporary, we're 2 years in, and much of the side effects are long-lasting and they're devastating. The most significant takeaway of that meeting is that the diagnoses of anxiety disorders and mental health issues are forever. Their children will never recover. As I said, I'm the wife of a school teacher, and I can attest to the fact that the look on my husband's face, my husband of 24 years, when he comes home from work, the hopelessness I see in his eyes for kids to recover, and to recover both academically and social emotionally, he said it's hopeless. Nobody's even talking about it. They are 2 solid years behind, and they will most likely never, ever catch up. It's very sad. Thank you.
Thank you. Victoria Gula. Good afternoon.
Hi, my name's Victoria Gala. I live in Spofford. I have a 9-year-old child with Tourette syndrome who has been denied a public education in New Hampshire because he can't wear a mask. I homeschooled him, and he's now in a Prenda homeschool pod, which ends at 1 o'clock in Gilsum, so I've been texting to arrange for somebody else to take him, since I'll now be late. I have mask-injured lungs. I wore a mask at the very, very beginning in the spring of 2020 to go grocery shopping and everything, and for whatever the reason, I have susceptible lungs, maybe because I've had throat surgery, just about 2 years before that. And I have a little bit trouble swallowing things, and things might get stuck. And so my lungs, for whatever reason, are susceptible to getting bacterial pneumonia. So when my lungs were injured and I kept having bacterial pneumonia and it was months and months and medication, it kept coming back through the summer, I started doing my research. That's when I found out the dangers of masks, especially for people with lung conditions, and that when you do have a lung condition or an illness, you should not be wearing a mask. You should be breathing fresh air, and you should be expelling the stuff that you don't need anymore out and away, and not having it trapped for rebreathing, whether that's food particles. I also learned that masks induce mouth breathing, and I learned about the harms of mouth breathing. I am a researcher. I have degrees in history and political science from McGill University, and I focused on the Eurasia area and basically studied totalitarian regimes and loved researching, writing papers, and so I just dove into this. I also worked in public policy. After college, I got a job. I actually worked for Governor Weld in Massachusetts in constituent services, and I did lots of research, answering constituent questions and replying to them. So the researcher and me went to work, and I found out all about the harms of masks. So I want to tell you about your nasal turbinettes. Those are your filters. There are 3 of them in your nose. All 3 together about the size of your fist. They go all the way up past your eyes. That is your filter. They are also the home of where your nasal mucosa is, your mucus. And in your nasal mucosa, you have IgA and IgG antibodies, and it's where nitric oxide is made. Nitric oxide comes from vitamin D from the sun. You cannot get this from a vitamin D supplement, though I encourage everyone to take their vitamin D supplements and maybe get a vitamin D lamp where you can get nitric oxide made through your skin. And your nitric oxide can kill viruses, molds, I should call it fungi because it's more than just mold, fungi and bacteria. When you're wearing a mask and you're moving, you're induced to mouth breathe because you're getting too much carbon dioxide. The pocket traps it and you get too much CO2, and so your body signals that you need more, and incorrectly we mouth breathe. That also stimulates the sympathetic nervous system. The sympathetic nervous system is, think about sympathy. So when you're speaking, you're mouth breathing. That's why when people are coming up and testifying, they might get more emotional. Because when we speak, that type of breathing, we're using the top lobes of our lungs, and it's stimulating cortisol and adrenaline. And we're not getting that the best oxygen and carbon dioxide exchange, what happens in our lower lungs. So think about these kids walking around schools induced to mouth breathe all day, and movement, and the poor teachers and the anxiety that creates from mouth breathing in your mask and getting too much carbon dioxide. The cortisol that you get will help the kids from falling over because you have a fight or flight reaction. Our bodies are amazing. That's why we have 3 nasal turbinettes to do this filtering, which the masks that induce mouth breathing are inhibiting. So we are not filtering all this gunk, and we are causing our kids and our teachers to be more anxious. Long-term cortisol production is actually a medical problem that should be seen by an endocrinologist to fix so that you don't have long-term damage to your body and your mental state. So again, that's what these masks are doing. I live down in the SAU 29, and as you may have heard, they just had to have meetings this week for the high school because of the violence there. The principal was quoted in the Keene Sentinel as saying several weeks ago that the kids have been separated away and isolated, and that they're not used to working with each other anymore. And we've heard about the damages of masks where we can't see each other. We don't have the signals. Our faces and our expressions show hundreds of cues that we learn as babies growing up, and the kids have not had this. They have been isolated and they have been damaged by these masks. Now the Keene school, where they would have about 5% of their students in Keene High School that are so disruptive, they're trying to find ways to expel them. And they have had 26% of their students this year have written up for different behavioral issues, but they find that about 5% are the real problem. Students don't feel safe going down certain hallways. They don't feel safe in certain bathrooms. There's all kinds of vaping. There's violence, pushing, shoving, all kinds. For decades, psychologists and people involved with the CIA and all, and people wanting to understand prisons, have been doing experiments with rats in cages where they zap them. And they want to do this to see how they can understand human behavior through being cruel to rats. If you take a single rat and you stick it in a cage and you zap it and it has nowhere to go, the rat will become a lonely, sad rat and curl up in a little ball, and that's how it copes. If you put a second rat in the cage, what happens? The dominant rat will come into a massive fight and will essentially kill the other rat. They have these rearing up behaviors and they fight with their front paws with biting. Rats that get repeated zapping stimulations will bite other rats. If you take rats and separate them and then put them back in, if you put them with other animals, they'll seek out other rats and attack them through repeated zapping stimulation. We've essentially taken our students in schools and made them rats in cages. I want you to think about everything that you've read about all of the violence in the schools, all the behavior problems, and I want you to go back and look up those experiments about rats in cages and think who used them: the CIA, psychologists, prison officials, trying to figure out how to handle human behavior. And I support this bill, and I urge you all, do not ever let this happen in this state again. Thank you.
I have an announcement. Did somebody here potentially leave this cell phone downstairs? Somebody lost a cell phone, so if you can spread the word, Carol will have it, and we'll leave it with security, and that would be great. Listen, I'm gonna have to apologize. We have let everybody speak without a time limit. I think there's still 15 or so speakers to go. I'm gonna have to limit all remaining speakers to a minute because the four of us have a 1 o'clock commitment. So I will now recognize Tricia and Reed Lambert.
Thank you, Mr. Chairman, members of the committee. Again, my name is Tricia Lambert, and this is my son, Reed Lambert. I really brought him with me because you really need to put a face to what is actually going on. I'm from Hopkinton, New Hampshire. I have two children that were in the school system. They both attended up until September of last year. Reed has an interesting name because Reed has a reading disability, and he has an IEP. Or he had an IEP, and he also has migraines. He could not wear a mask. He was not wearing a mask last spring, and he was not wearing it in summer school. Something changed that came in the fall time frame, where suddenly he had to wear a mask because they signed for ESSER funds, ESSER 3 under ARPA, or the American Rescue Plan. And now he was forced to wear a mask, even though his IEP had language in there that they had to do anything possible to combat what COVID was doing for his learning. He had a teacher in the 4th through 6th grade that taught him how to read. And she explained clearly how important it is for your mouth to move and for them to see your mouth both ways. And that without that, how are they learning how to read? Reed is the face of those children who have disabilities and those who are just learning how to read, that they are not getting the education that they need. Come September, we walked into school along with his sister Ava, and we gave a do not consent, which I find interesting because they can't put bug spray or give them a Tylenol without our consent, but they can put a mask restricting their oxygen. They walked in for almost 18 days and they were rejected. I'm going to read to you what they wrote us on why they could not attend class with their peers. On Thursday, September 2nd, this was the first day, I met with you to discuss Hopkins School District's mask mandate. Since Reed and Ava have been asked to wear a mask while attending school and refused to do so, they will be suspended today in our in-school suspension program. At any time during their suspension they decide to wear a mask, they will be welcome to rejoin their classes. I'm not sure, but I think Nuremberg Code pretty much does not permit that. It's something, you do this or else. And that is exactly what happened. They are now both homeschooled, and they are getting their education. I thank you for moving this to here. This is the best classroom for him to experience this, and I really appreciate it.
Okay, thank you very much. Reed, do you have anything to add?
Oh,
You can add.
okay.
But 1 minute.
Wait a minute. Okay.
You get two.
So basically, we went in there every single day, and we went there to go basically get this certain paper. They did it for 3 days, or 4 days actually, because Mr. Kelly wrote it with his signature on it, meaning he's valuable for this stuff. And secondly, the mask mandate was not even enforced. They had a vote on it after. So Mr. Kelly, out of his own hand, kept me out of school. So I didn't have school all these days, including my sister. So we drove from school home every single day. So, and the other person that's secretary to this as well is the assistant principal of the high school. She also signaturized this, but Mr. Kelly really didn't want to stand there and listen to us and sign it himself.
Okay, thank you very much.
Thank you.
Brian Hawkins, 1 minute. 1 minute, please, Brian. Followed by Frank Karnak.
I'll keep it to 1 minute. Thank you, Mr. Chairman, members of the committee. For the record, Brian Hawkins, today representing NEA New Hampshire. We are here in opposition to HB 1131 for two main reasons, and I'll hand in some written testimony that'll elaborate on that. But the first is throughout the pandemic, when most schools returned to in-person, they did so at the recommendation of having universal masking by the CDC and by the New Hampshire Department of Public Health. Governor Sununu, Dr. Chan, all commended schools for their low transmission rate for the low transmission rate that took place in schools. And a lot of that, from some Duke research that I'll submit to you, has shown that 72% less transmission for those schools that have universal masking. My second point, this is with respect to the violation at the end of the bill in Roman 3, reads that an educator shall be considered in violation of the Educator Code of Conduct, justifies disciplinary sanction by the Board of Education. This is sort of a cavalier addition to adding this to the bill. The Professional Code of Conduct established was not for this purpose. This is just the purpose of the Code of Conduct was to establish a set of rules and standards around professional conduct, and it is defined in Ed 50102 as a set of established professional norms and behaviors having to do with conducting oneself as a certified New Hampshire educator. So we don't feel that enforcing a policy which is adopted by your school board is something that would risk an educator losing their license over. There's a difference here, I think, between following a policy and following the Code of Conduct, and the two shouldn't conflict. You shouldn't risk losing your license because you're afraid of losing your employment. And I'll stop there.
Thank you very much. Frank Karnak, I think, from ACLU. followed by David Cope. 1 minute, please.
Mr. Chairman, members of the committee, thank you for the opportunity to testify. My name is Frank Knack. I'm the policy director with the ACLU of New Hampshire. A couple of quick points. One, major medical associations recommend universal indoor masking for K-12 schools under certain conditions. The CDC, the American Academy of Pediatrics, the AMA recommend it when community risk is high. And the American Academy of Pediatrics and the AMA also have recognized that certain communities are more vulnerable, including immunocompromised children, and recommend it beyond just the high risk level. And blanket prohibitions like this bill would do conflict with these recommendations of the major medical associations. In addition, children with disabilities, including a range of underlying medical conditions, are at increased risk of serious illness and death from COVID-19. And under both the Americans with Disabilities Act and Section 504 of the Rehabilitation Act, public schools cannot exclude students, and they have to have reasonable modifications when those needs arise. And prohibiting schools from taking reasonable accommodations, which this bill would do, place parents in a situation where they basically have to choose between their kids' health and their kids' education, and that is a place that no parent should be put within. And multiple federal courts have had this question now before them, including the 8th Circuit last week, the Western District of Virginia, the district in South Carolina, and all have come out and recognized that blanket prohibitions like this are a violation of the ADA and the Americans with in the Rehabilitation Act. So I'll leave it at that and point you to my written statement.
Thank you very much. Mr. Cope, followed by Shauna Healy. 1 minute, please, sir.
Good morning, or good afternoon. I'm David Cope from Hancock, New Hampshire. I agree with a lot of the stuff that's said in support of the bill, which I am in support of the bill. One of the concerns I have is that my wife and I did communicate quite a bit with the superintendent and school committee during the last couple of years, because I did read the literature and came to the conclusion that masks were not effective and had harms. The school committee basically deferred to New Hampshire Department of Health and the CDC. So in my view, those authorities were not following the science. And so in other words, it wasn't follow the science, it was follow the authorities. But our authorities failed us very badly. And so I am worried going forward about a similar situation happening, where it's just follow the authorities. Follow the science is great, I'm all for that. But follow the science authorities, they've lost my trust. I think they've done a really bad job. So that's why I'm in support of the bill, because I want to prevent that from happening again. Thank you.
Sir. Shauna Healy, followed by Colin Healy. Good afternoon, ma'am.
Good afternoon. My name is Shauna Healy. I live in Southampton. This is my son, Colin, who will be speaking. What we have witnessed over the last 2 years has been the greatest psychological operation of all time. People have been convinced of the lie that they should be wearing masks for safety or to protect others. I find this especially evil when perpetuated on children. There are countless articles, data, peer-reviewed studies. You've probably seen most of them. Yet people are choosing to ignore that science while instructing the rest of us to follow their science. Paul Alexander, who is a multi-PhD epidemiologist and whose credentials include working for the World Health Organization, US and Canadian governments, as well as being an advisor to President Trump when this all started. In the beginning, when the NIH and the CDC started talking about masks, he sent an email with the best, most peer-reviewed, most scientific studies about how bad the masks were. After that, without his knowledge, members of the NIH and the CDC destroyed his career immediately. They took one sentence from one email out of context and sent it to every media platform they could to ruin his credentials. That's a lot to ruin the career of one man and keep the mask charade alive. Despite the gaslighting, shaming, and virtue signaling we have all witnessed, there's something beautiful happening at the same time. There's an awakening. This has started a movement a momentum that will not be stopped among parents. We're saying no more. You will not mask our children on the false promise of safety. You will not tell us you care about our health while ignoring how sunshine, diet, healthy diet, and movement play the biggest role in our outcome in any illness. The greatest threat to our children is to allow our government to determine what is necessary for them to be healthy and well. The number of parents who will not tolerate this any longer is growing exponentially. You continue to encourage us to homeschool, to build co-ops, and create learning environments so meaningful, we won't need to mask our children and send them to your government-funded schools ever again. Thank you.
Thank you. Hi, Colin.
My name is Colin Healy. I live in Southampton. My town has 85 kids in kindergarten through 8th grade, and they have worn masks for 2 years and just stopped after February break. My older brothers go to a school of over 400 kids, and they haven't worn masks all year. There is another town in the same district as mine that has 350 kids, and they did not have to wear masks for most of this year, but my town did. This doesn't seem like it's about being safe when each town gets to make their own rules. There wouldn't be one school that requires masks and one that doesn't if it's about safety. There wouldn't be one sports arena that requires masks and another that doesn't if it's about safety. There wouldn't be one restaurant or store, etc., that requires them and another next door that doesn't if it was about safety. If they worked and were necessary, people would just wear them because they wanted to. The more you try to force us into wearing them, the more you prove it's not about safety. Please support this bill.
Thank you. Lisa Dean, followed by Nancy Brennan, and really, please, folks, we all have commitments at 1 o'clock.
Lisa Dean, Stratum. I'm in support of this bill. The elephant.
Point the mic at you, some of the people have a hard time hearing.
Yeah, no problem.
Thank you.
Lisa Dean, Stratum. I'm in support of this bill.
Is that a Red Sox?
This?
Yeah.
I'm getting there. I'm getting there. Ready?
Oh, okay.
I'm ready. Ready? The elephant in the room in the USA is masks on school children. The elephant in the room in New Hampshire is masks on school children. The elephant in this room today is masks on school children. We know this, and you senators know this as well. My daughter made this elephant. My daughters were masked all of last school year and until recently this year. Each of you senators are aware that thousands and thousands of New Hampshire children were masked in school. But another elephant in the room in New Hampshire is that thousands and thousands of other school children were mask optional. Many schools have been mask optional last year and optional this year. Many schools in the same counties, in the same towns and cities, many only a few miles away from each other, were optional. We know this. It makes no sense, none. A mask is a medical device. We allowed unqualified school board members and superintendents to mask children willy-nilly. Many times those school board members don't even wear masks, yet they vote to mask children. We know this. This is unacceptable. Another elephant in the room in New Hampshire is when children step foot off school property. There's basically no mask requirements. Sports, concerts, movies, sleepovers, restaurants, you name it, no masks on children. It's only on some school properties, some school board members vote to keep children masked. Yet schools up the street, next town over, no masks. This is unacceptable. Schools in the same cities and towns, remember, it's apples to apples with cases and deaths. Schools only a mile away, mask optional all year. We all know the mask game school boards and superintendents played on these New Hampshire children. We can't allow it ever again. I ask each of you senators to dig deep, remove your other influences from the School Board Association and others who have your ear and want children masked. It's not okay. The decision must be left to parents. This decision can no longer be left to school board members and superintendents. They abused it. They abused children. Children got decimated. This is not a secret. I'd like to remind you, 100% of the public testimony from the House Committee, which went on for hours, was 100% in support of this bill. These are our children, not the school board members' children. As adults, we have a moral, ethical, and humane responsibility to take care of children. You have the opportunity to take care of New Hampshire children and do the right thing. We all know what the right thing is, and it is to support this bill.
Let's get the elephant out of the room in New Hampshire. Let's let our children live free and breathe free, not live free and mask. Please remember the elephant when you go vote. I ask you to support this bill, and thank you for your time.
Thank you. Nancy Brennan.
I speak today in opposition to this bill. Before I came here, I was at the Memorial Building at Concord Hospital to have a procedure done. There were mask requirements throughout that building. I saw people of all ages, from young children to oldies like me. No one was protesting. No one was saying they refused to wear a mask. In fact, the only person I have seen in the last 2 years in a medical facility without a mask was a person who testified today, is a medical professional, and gleefully took a picture of themselves in a medical facility showing they could get away without wearing a mask for some reason. No one was gasping for breath. No one was needing to be revived because they had been sucking in CO2. No one was complaining that their child was being abused. Now, are those doctors and nurses conspiring to take away our God-given patriotic freedoms? Or do medical professionals perhaps know something about the spread of infectious airborne disease that the sponsors of this bill are either ignorant of or are just dismissing as another attempt by the left to control our lives? To lift mandates in places where the virus is finally slowing down is reasonable. But to pass a law that no masks can ever be mandated for any reason in a school setting for any child or any adult, no matter the issue, seems to me both foolhardy and short-sighted. Yesterday, I sent this committee 49 scientific studies that show masks work when the correct mask is worn by everyone in the setting. When I leave here, I'm guessing you're not going to vote on this today, I will send you the reports I read that show that except for a tiny, tiny subset of children, children are not harmed by masks. And I will say that the fact that there are children, there are adults that really can't wear masks is the reason we need to say no to this bill in case we need it to protect those people the same way that we inoculate our kids against measles so that that vulnerable kid who can't get the vaccine doesn't get measles. Thank you.
Okay, thank you very much. Gary York, Dr. York. Good afternoon, sir. Followed by Charles Smith.
Thank you, Mr. Chairman, and thank you for accommodating the audience today. Gary York from Hopkinton, New Hampshire. There's a lot of talk today about the risk and benefits of the masks on school children. The basic question is, why do we have masks for children? Are we trying to protect the children? Why should we be afraid of protecting the children from getting COVID when there's no real danger for kids in school getting COVID? The risk of the mask is not getting them immunity, natural immunity, robust immunity. So when I see kids in the back room playing together, sharing food, sharing clothes, sharing masks, why should we be afraid of them playing together like that? I think we lose an opportunity for kids in school to have natural, robust immunity from exposure to a mild case such as Omicron was this past variant. So let's not be afraid of that. Thank you.
Thank you, sir. Mr. Smith, please, followed by Emily Phillips. Mr. Smith is not here. Ms. Phillips, good afternoon.
He was going to speak, but I'll speak for him. He's asleep. My name's Emily Phillips. I just finished my 3rd year serving my community as a school board member, and I want to speak, not to be redundant, I know you've heard enough. I don't think school board members want this responsibility, and we always said the past 2 years we were hoping the state would make some law about this so we wouldn't be fighting with members of our community over masking children. But my particular district did face coverings the past 2 years. We were open the whole time. We love that. I want to talk about my 2 children and other children like them. They have disabilities, and the facial coverings being required, we made an accommodation for kids with IEPs and medical reasons to wear plastic face shields. That was wonderful and appreciated, but what it did was heighten the chance of bullying, and my 3rd grade son was excluded from working with certain peers because those children were told or spoke up and said they didn't want to work with kids who couldn't wear face masks. So I just wanted to say that it would be great if we would support this bill and just not allow it to be an option, because it's making disabilities that were invisible very visible. And I know we all know about the social emotional detriments that this pandemic has caused, but we need to think about how masking children have made children look different to other children who can't wear masks. So thank you.
Thank you. Camila Franson, followed by Patricia Myers.
Good afternoon. I'll be very brief. Don't want to be redundant. There have been a lot of wonderful testimonies here today. I am here in the capacity of a concerned citizen of New Hampshire, a parent. I am also a doctor of chiropractic with a long background in immunology and health and wellness. I've studied the human frame for 30 years. And I was delighted to hear that the bill passed the House. But what concerned me was that there was only a 9 vote majority. And I looked at the numbers, and out of 323 House members, 157 voted against this bill, which means in essence that they're voting against our children. And I know that you, ladies and gentlemen, took this job, ran for office and so on, for the sake of improving the state and looking out for the citizens. I think after this, the testimonies from so many experts, distinguished experts and parents here today, I do not see how anyone can not vote for 1131. On a personal note, I'm here not because I have personally experienced a school where my children are in a school that now does not have a mask mandate, mask optional. And the difference this year compared to last year is night and day. My kids love school. Last year was a complete struggle. And this year we're back. There's a small number of students who do choose to wear a mask. All power to them. That's their choice, as it should be. But please, let the parents decide whether that is the right option for them. I was born and raised in Sweden, and as many of you may know, Sweden kept a very open door policy throughout the entire pandemic. There were no lockdowns. There were no mask mandates in school. They kept the kids in school, and they do not see the level of depression, anxiety, and other social, emotional, and health problems that we see here in America. And the rate of excess death is much lower than here as well. And so I ask you to please support this bill, put the power back with the parents, That's all I have to say today. Thank you.
Thank you very much. Patricia Myers, followed by our last speaker, J.R. Hole, former Representative Hole. Good afternoon.
Good afternoon. Patrice.
Patrice, sorry.
Thank you, from Concord. You've heard a lot of testimony about how this has affected other people and the studies that have been done, but nobody's talked about how it affects you as senators. We operate under a constitution which delineates our inherent rights, and one of those rights is to breathe fresh air. One of those rights is not to be mandated or forced into taking things into our bodies or wearing things that are detrimental to our bodies. You all took an oath. So did the school boards. So did the town councilmen and selectmen and whatever. And you have bonds. The schools are not exempt from operating under the Constitution. But the people who elected them or appointed them are as well. That's all.
Thank you. Good afternoon, J.R. How are you?
Good afternoon, Senator. For the record, J.R. Hole, former state rep, 2010 to 2018. I'm here for two reasons. One is on behalf of Reopen New Hampshire. I have a petition that you guys have seen. I'm going to turn it in. There are 5,200 signatures on this one. We have another 111 or something that have come on the website since then. You've heard from a number of our members today who have shown up in person. You've heard from some lobbyists too, and universally, the people that supported this bill are the citizens. The people that oppose this bill are the lobbyists. I could talk about a lot of things. I could talk about how hearing impaired who are used to lip reading are disadvantaged. I could talk about how it impacts oxygen. I could talk about efficacy of masks. I could talk about the fact that I have a number of patents, some of which are in the medical field. And I don't know whether it's Dr. Senator Sherman or Senator Dr. Sherman, but either way, right? I appreciate that medical field is valuable, okay? If I were to submit a 510K submission on masks, okay, it wouldn't fly. Okay, I do medical product development. Okay, when it comes to diabetic medical care level equipment, whether it's glucose meters or peritoneal dialysis machines, I have a standard to meet to put something in the FDA. This is a medical device. If it's supposed to save somebody, it's a medical device. It is not used appropriately. It is not installed appropriately. The children swap them in school. There are real problems. We could talk about vitamin D. The fact that the state has not even discussed it in any of the things that have been public announcements and how valuable it is to fighting this virus, but we didn't. I can say that the citizens would like to see you guys represent their values on this vote and not just kowtow to the lobbyists. Thank you.
All right. There's one person who raised her hand. That'll be the last speaker. Thank you very much.
Hi, thank you very much. I'll be very quick. My name is Louise Spencer from Concord, New Hampshire. I'm co-founder of the Kent Street Coalition, which is an all-grassroots volunteer advocacy organization. I can't let sit the idea that it's only lobbyists who oppose this bill. Our members oppose this bill. Many members of the public oppose this bill. We can talk about the pros and cons of it, but we cannot make a claim that it's lobbyists alone. And also, lobbyists often speak on behalf of a lot of members of the public, and we should not forget that. So thank you for taking my testimony.
Thank you. There's a representative of the Department of Education if anybody has any questions, but I think given the fact that we all have commitments, Ms. Fenton would be amenable to questions offline. Okay, so with that, I just want to apologize for having to have to move the hearing to everybody that was inconvenienced, and thank you for being here.